Good. Great. Welcome everyone to the February meeting of the Universal Health Plan Governance Board. I'm Helen Belanca, the chair, and let's get started with the roll call.
Yes. Helen Belanca,
Here.
Chun-Wei Chi,
Here.
Amy Fellows.
Here.
Michelle Glass,
Here.
Bruce Goldberg is on leave, Judy Richardson.
Here.
Cheryl Ramirez.
Here.
Mary Lou Henrich. Here. Michael Leahy.
Also here.
Thank you, everyone.
Great. So a quick agenda review. We have a brief consent agenda and then our executive director report. We're going to have a board discussion that is a follow-up from our last meeting regarding sort of our overall plan and timeline. And then we're going to have a detailed discussion about expenditures today and make sure the board is well aware of where we stand in terms of our predictions for expenditures for the Universal Health Plan. Then we're going to have a presentation by Dr. Chun-Wei Chi. He's recently back from his travels and is giving a talk for us on global efforts for universal health care. And then afterwards, we will have committee updates. We are going to save some time today for our federal and state policy updates. We've been skipping that section in the past few meetings, so we want to reserve time for that today. And then next steps and public comment. So we have several items on our agenda that are for voting topics. Besides the consent agenda, we have possible vote on our meeting time and location. We're going to have votes on proposals for eligibility and subrogation from the operations committee. We'll have votes to establish our transition committee, and we will have a vote on our behavioral health proposal. My understanding is that all the folks that have signed up for public testimony, it looks like everyone signed up for general testimony and nobody on voting topics. Okay, is that accurate? Okay, cool.
I signed up early, I don't know.
I don't see your name, Tom.
No.
Yeah, he's on there. On the list I gave you.
Sorry, I don't have it.
Having just a few technical difficulties with one of that.
Oh, okay.
Let me see, Isabel.
All right, sorry, we are working on a new system here, and let me see, so, okay, so we have one person for, a voting topic, okay, so. Before we begin, I want to point out that, we're entering a new phase of our work as a board, where we're going to have to make some difficult decisions regarding our recommendations to the legislature. We need to focus our time on deciding how to reconcile the many proposals that have come to this board. We've had a lot of questions lately about our process, about our meeting time, about our schedule of work, about our approach to getting this done. And of course, you're all welcome to question those things, board members and the general public alike. But I'd like to remind you that all of us are here for the same reason. We know that our current healthcare system is unjust, inefficient, and unaffordable. Every one of us wants to see that change and change in a meaningful and lasting way. There are many ways to go about that change, and I'm sure that 10 different leadership teams would have 10 different approaches to it. None of those is the right way. Judy and I have worked with Mimi to develop a plan and a process to get us to our deliverable. And while I feel certain that it's probably different than the plan any of you would develop if you were in these roles, I'm confident that we're going to get where we're supposed to go. This board has been given an enormous, complicated task and very limited resources to accomplish it. We have to cut off conversations and limit meetings because our time and our financial resources are severely constrained. I know that's not ideal. I didn't build it this way, and I wish it were different, just as many of you do, but I'm asking all of you to understand that it's necessary. We're all on the same team here. We all believe in this work. I'm asking all of you to extend a little grace to the staff and to Judy and I as we navigate this process. We have an imperfect process and it will be an imperfect product, but I know we'll be able to make the case for this work to continue. So with that, I'm going to review the public comment that we've received. At our January meeting, I missed a couple of pieces of public comment because they were posted late to our
Before
website.
you go into public comment, did you want to do the consent agenda vote?
Yeah, we can do that first. Okay,
That's what's on the agenda.
Okay, let's do the consent agenda vote. So in our consent agenda today are the minutes from January. as well as our policy, our delegation policy, in which we delegate much of the roles of this board to Mimi. Is there a motion to approve our consent agenda?
I have a question about minutes, one thing. How do I do that? And
Sure, and you want to pull it off is it you can pull it off the consent agenda and have a discussion?
it's not as substantive, but I'm just never quite sure when I read the minutes and I find them something, I don't want to disrupt or
Right,
anything, but I'd
right.
like to.
So the process, if you want to make a correction or adjustment to the
Yes.
minutes, you can always submit edits to the staff, to Mimi and to Isabel. You don't, if it's substantive,
No.
then it would be part of the discussion.
Okay.
But it doesn't have to be part. The reason I sent a consent agenda is overall, we're approving it.
Yes,
And if you have edits, you can send them to the
okay,
staff.
thank you, just to know the process.
Yeah.
Okay.
Go ahead, Judy. Is
I'll move to approve the accept the consent agenda as presented.
there a second?
Second,
Is there any discussion about the two items on the consent agenda? Okay, all in favor? Let's do a roll call.
Helen Belonka,
Yes.
Chen Wei Chi.
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Michael Leahy.
yes.
That's our.
Okay, great. So getting back to public comment. Last month, there were several pieces of public comments that were not mentioned because they were posted late. So I'll start with those. Megan Beck wrote on behalf of 282 Oregonians and Healthcare for All, asking for more opportunities for public engagement. Alyssa McFarland wrote in to encourage us to consider a model like One Medical, where all the clinicians are salaried and paid the same regardless of volume. Charlotte Maloney wrote to express concern that the draft plan we presented to the legislature includes a public option. Just to clarify, no draft plan has yet been submitted to the legislature. That was in our annual report. Karen Baker wrote to ask if there will be a state-owned pharmacy and whether there will be a provision to offset the cost of medical and nursing education, and to say that many people would not be opposed to small co-pays in our plan. Mike Huntington wrote to clarify how specialists were paid in the collaborative care model in Seattle, which he also gave oral testimony on. Again, my apologies for missing those. But then this month, the written testimony includes Melanie Cambron, who wrote in to say that a 9% income tax was far too high for the middle class, and that this plan should be financed by taxing millionaires and billionaires. Lou Sininger wrote to oppose the household size adjustment, asserting that it's not fair and not in keeping with the principles of universal health plan. Matthias Margus, with 5 co-signers, wrote in to recommend that the UHP financing meaningfully tax the wealthy and be based on public operation, global budgeting, and progressive taxation. Todd Ferris wrote to ask us to terminate our contract with Milliman, since the estimates they gave us are based on the status quo system and do not account for the savings that can be realized with the universal health plan. Dale Locke contacted us from Canada to say that we should not pursue this plan because healthcare in Canada involves long wait times. David Moore, Tyson Tucker, Bruce Thompson, and Tom Sinsick expressed general support for our work. Warren George wrote in to express disagreement with my categorization of our work as pursuing a unified financing system instead of true single payer. Jacqueline Naganuma submitted comment on behalf of about 200 co-signers opposed to value-based care. Leon Boat, forgive me for pronunciation, submitted comment opposed to value-based care. Megan Beck with 200 plus co-signers wrote to encourage us to use a progressive funding mechanism, specifically using the same effective tax rate for all Oregonians, regardless of employment status, implementing a wealth proceeds tax based on the net investment income tax, to continue the F&R meetings until September, and to request that we contract with either the Institute on Taxation and Economic Policy or the Oregon Center for Public Policy in our work. And that concludes the written public comment, and we will give 2 minutes now to Tom for a comment on one of our voting topics. And can you let us know which topic you're going to be?
It's all the things that you're voting on, because this is about the process of the voting and the items related to each of those items.
If it's not on something we're going to vote on,
Yes, it's about the items you're voting on.
which
So,
one?
Items,
So we hold this time specifically if you want to
understand.
influence our vote. If
I-
it's about our general process, then. you
no,
can-
it's about influencing the vote.
Okay, go ahead.
Okay,
We'll give you 2 minutes.
okay.
Get closer to the,
Up.
to the, ow.
Should we?
Over there. Okay, thank you.
Here, thank you.
Thank you very much.
I can't display the timer, but
Okay.
I have it.
Leading into my comments, I'd like to focus on ORS 751. That is the board that is determining all of these things, including how the chairperson is elected, powers necessary for the performance of the functions of the offices. The board shall meet at the time and place determined by the board. The board also may meet at other times and places specified by the call of the chairperson or majority of the board. The board may establish any advisory or technical committees the board may consider, etc. The board shall determine the representation, membership, terms, and organizations of the committees and shall appoint the members of the committees. This relates to all of the voting topics that I was glad to see these on the agenda today for the board to make the determination. I'd also like to add just a brief comment about the financial resources. We're not given the original financial resources. We know that. Advocates will continue to do the fight for the work to have these things reinstated. And that for now, in the future, is the role of the advocates to fight for what you need. Thank you very much.
Thanks, Tom. Okay, so moving on now to the executive director report. Go ahead, Mimi.
All right, good morning, everyone. I'm Mimi McDonald. I'm the Executive Director of the Universal Health Plan Governance Board, and welcome. Excited to see so many people here today. Thank you for coming. Thought I'd provide a few updates about some of the work happening at the just with the Universal Health Plan Governance Board in general. First off, is that we've been working on what's called a policy option package. When I say we, this is a UHPGB staff, and of course, all of the board as well will be informed. This is a preliminary option package for the 2027-2029 biennium. So absolutely happy to get any feedback on I guess a wish list, as you would call it. What is so far gone into the bucket is substantial funding for information technology, public engagement, and financial and economic consultation. Obviously, as more details are fleshed out, we'll provide more information of that. Other things that are happening, this is actually with our staff, is that within the month of March, staff are helping support, in addition to all of the committee meetings that are happening and the kickoff meeting of the transition committee, we're also helping support 15 to 20 targeted engagement meetings in March. So in March, excuse me. So just to kind of give people a sense of what the staff are currently doing, and that we are spread a little bit thin, so people understand sometimes things perhaps might not get posted in as a manner as people would wish. I wanted to bring up, and this is not something that is definitely going to happen, but I wanted to bring up the potential for the board members to discuss. I anticipate that there will be times in the upcoming months when a specific topic will sort of have a time constraint, and there may be times when the board might consider having perhaps one additional virtual meeting sort of mid-month. I'll give the example potentially of when the report from the public engagement meetings are available. It may be very challenging if we have to wait an entire month until the board can hear all of that information. So that is not something that is necessarily going to happen, but for the board to discuss. And then I wanted to talk about board outreach. So as most of you are aware, based on our policy, individuals who are board members, when they do speak for the board, they go through a very specific process. Usually the appointed speakers, usually me, but I can't be everywhere. And if other board members are willing and able to speak on behalf of the board, they we have a process where they let staff know, and then they use a very specific presentation that has been very thoroughly evaluated both at the board level and with our CECC committee chairs and with our consultants. So having said all that, we're really grateful. Board member Michelle Glass has already done one speaking engagement for HCAO, and I know has another one on the books. Vice Chair Richardson and myself are going to be speaking in our hometown, the Dalles, at a POP meeting talking about the UHPGB. Chair Belanca will be speaking at the OHPB, Oregon Health Policy Board, coming up next week, I believe. So just again, keeping everyone apprised of what's happening. All right. Oh, good. So just very briefly, because I know, just wanted to give an update on our budget, probably the most important things to look at. If you go to the very bottom, you'll see expenditure totals. So we have our working biennial budget, actually 1.8 million. You can see where we are with the actuals to date, just through December of 2025. We have our actuals and planned. So what we really anticipate spending, and then that number 61,000, that tiny small little number is what we have in reserve for some contingencies. I will mention that that number is actually going to be smaller than that just because of some of the additional charges that are coming through via the state and DCBS relating to rent in this office, which they had not been charging temporarily, but then are going to come back and charge that. So I'll give that update at the next one. I did want to update people next just on our contracts with our consultants. So people can take a quick peek. The numbers that have an asterisk with them had a slight increase, and they're not to exceed by 25%, actually, for all, not for all three of those, but for Echo Northwest and for Wentz Jackson, their not to exceed was increased by 25%. Milliman was increased by approximately 10%. And then you can see the balance on the fourth column down. So not a huge balance. So that's where we're at with our consultants. And I'll pause there if we have any questions. All right, that is it for me, unless there's any questions.
Not a question, but Isabel, could you put, okay, so that you can see Michelle's face?
No, sorry,
Feels
we
like
are
this is a room with-
so,
Thank you.
yeah,
There we go.
and apologies, we are definitely challenged today. So since I'm driving, so if anything happens wrong, just blame it on me. It's not Isabel. All right, so,
I guess I had a question.
yes,
About, I know with the Finance and Revenue Committee, Morgan Shook, Echo Northwest.
yes,
Contact, has been great. And I guess I would like, I said that at the meeting, and I want to say it here, it's been very helpful. And so these increases, these numbers don't really help me understand how much more they're able to give or not give to these processes, and is it enough? And are we gonna be left hanging, or, you know, and because it sounded like Morgan was gonna be doing some more, so maybe that's why that increase, and just kind of like, where are we at in terms of feeling like we've got enough of the consultants that we've got to do?
yes. Well, certainly within their scope of work, they're absolutely able to meet their scope of work and all of the deliverables that they have contracted. Some of the extension did have to do with kind of the delay in the Milliman contract starting, and then that availability of that information, the work of the Finance and Revenue Committee was contingent upon that. So really what you can see is what's in the balance column. Although of course it is actually smaller than that, because that was, well, actually that's fairly well updated, but it's still not, they are, like I said, they have enough funds to do their deliverables and their scope of work. So and see, that's where you are with that. And I'm gonna start. You guys all see that, and then I'm gonna turn it over to Chair Balaka.
Great, so I wanted to start by just kind of getting everyone on the same page. Some questions have come up about our timeline regarding committee work and our ultimate deliverable of our final report to the legislature in September. And so this is just a way of just kind of reminding us how little time we have left and the enormous amount of work that this board has left to do. Our original timeline has been delayed and kind of pushed back a little bit, crunched into these final few months, partly because we had a complete staff turnover with a new executive director, a complete new staff, and partly, as Mimi just alluded to, the delay in getting our contractors on board, which set us back about 6 months in a 2.5-year process. And so these final few months are going to be a real crunch time for us between now and September. So we always refer to our final report being due in September, but I'll remind the board that that means that this board has to approve our final report, the final draft of our report in our August meeting. which means we have to have a first draft to consider in July. And so really all of the decisions and reconciliation and the major work to put together the plan has to be completed by July so that we can review it all in context and consider other factors. The process of getting there is going to be pretty complicated. On this slide, I just want to point out that of our committees, 3 of our committees, the Finance and Revenue, Plan Design, Expenditures and Operations, will be ending their work in March, but they will still have proposals to bring to the board in April. So even up till April, we will still be considering proposals from those 3 committees, in addition to launching our transition committee and starting to hear proposals from them. So May is the first time that we will have all the proposals in and be able to consider all of our proposals in context and reconcile them with each other. So that means we have May and June to have some very hard discussions and make some very big decisions to get a final report together by July. That's just 2 meetings, and that's very barely enough time. So so I just want to point that out, and that's the reason for our timeline set up the way it is. Go ahead, next slide. The board's absolutely committed to delivering a report to the legislature that provides a playbook on how to cover everyone in Oregon under a unified financing strategy. That's the language that we are using for this work. And we also need to consider how different markets might be brought into the UHP in different ways and on different timelines, and how to ease the economic impact of universal health plan on households, businesses, healthcare industry, and the state. So when we talk about different segments, Medicare segment, the Medicaid segment, the commercial segment of the market, and how the expenditures and revenues for each of those sectors might look different, that is because we need to think about how this whole plan would be rolled out long term. It doesn't mean that we are any less committed to a universal health plan that covers everyone under a unified financing strategy. We are absolutely committed to that, but we need to break the market down to understand how different components will function in different ways and how each of them would be brought in a different way under the UHP. Next slide. So why are these 3 committees, Finance and Revenue, Plan Design, Expenditures and Operations, why are they scheduled to end in March? First and foremost, because their deliverables have been met, or they will be by March. And the board needs time to reconcile all the recommendations from all of our committees into a unified plan. The consultant contracts for Echo Northwest and Milliman have run out. As Mimi said, we've had some extensions on those so they can help us with that reconciliation process, but they will really be at the service of the board at that point and won't be able to be at the service of the committees any longer. Also supporting the committees by our staff, Mimi, Isabel, and Lee. Brief applause for Mimi, Isabel, and Lee. Right? They do an enormous amount of work to plan, to host, to record, and then submit minutes, and then do all of the follow-up for all of those committee meetings. It is so much work that they are involved in for those committees every month. They've done an outstanding job with it, but they need to turn their time and their attention to the other work of the board. And so that is the other reason why we need to end those 3 committees so that our staff time can be devoted to this other work. Next slide. Artemis Consulting is working with this board, and they are charged with presenting our plan to various interest groups, including the business community, the healthcare industry, and consumers. And their job is to take what we've talked about and decided and put it in front of these interest groups and get their feedback on it. That's their job. They can't do that unless we've completed, we tell them what we've decided. And so part of it is just sort of coming to a decision around what our plans are shaping up to look like so that Artemis Consulting can use those plans to get feedback from those groups. If we are still changing those, and we'll of course consider their feedback and change them when Artemis returns with their report, but they need some questions answered before they can get started. In addition, we are launching the transition committee, hopefully today, later in this meeting. And the transition committee needs to know the decisions of these other committees so that they can think about how to get our system from its current state to its future state. That transition process will be long and complicated, and they need to know the details of the plan in order to do that work. And then, as I already mentioned, although our final report's due in September, we need a first draft by July. So it just limits our time. Next slide. Mimi touched on this already. The staff work over the next few months is going to involve planning, staffing, and supporting the revenue committee and the transition committee, supporting the 15 to 20 targeted outreach committee meetings with Artemis, consolidating all the work of the 4 committees into a draft plan for us, ensuring the contractors submit their final technical reports, drafting the final report, and then building a timeline, work plan, and budget for the 2027-2029 biennium. Next slide.
Can I ask
I
a
just,
question?
looks like Amy, I'm almost finished here. I want to remind the board that our funding for this work and for our staff ends June 30th, 2027. That's what we're funded for. We will not have staff or support for the board after that time. And if we want this work to continue, it's really imperative that we make the case for what we're trying to do to the legislature so that they continue to fund some iteration of this board. It may not be this exact board, it may not be the way it looks now, but unless we get buy-in from the legislature in the next session to continue this work, then all of this will just be shelved and put on the shelf and like dealt with some other time, the next time it comes around. So our main goal with our report is to get buy-in and interest and support from our legislative partners so that this work can continue. We need to spend some time thinking about what we're gonna need from the next phase of our work. We are in no way delivering a finished product. There's so many gaps in the report that we're going to be submitting to the legislature in September. And there are many years of work that are going to be involved in order to get to a final plan. So we need to figure out what that work is going to be, how much it will cost, what are the resources needed to delve into more of the details of the plan. So that is the work between September and the start of the 2027 session is to build that support in the legislature so that we can continue the work. And then go ahead, Ms. May.
Back to the previous slide. Planning, staffing, and supporting the revenue committee.
That's a
Is that
typo.
transition?
It's transition committee.
Okay,
That's a
thank you. I
typo.
just wondered if there's another
Yeah.
committee I hadn't heard. of.
Yeah, sorry.
Thank you.
Sorry. As a- All right, realize that as I read it.
Thank you.
Okay, next slide. Okay, so where we are in this journey, Chunwei offered us the language of building a playbook, which we all agreed was a really great way of framing it. This is not a detailed plan. We do not have the time or the resources to work out every details of how this plan would work. This is not a plan that we can submit to the legislature and then they're just going to implement. We are very far from that. What we're trying to do with this plan is create enough of an idea of how this plan would work that we get interest and support from the legislature so that real investment in the work actually occurs. And that's both time and resources in terms of people and resources in terms of money. So we need to answer key questions about how the revenue strategy would work. We need to have a plan for cost containment. We need to show that this plan is better for businesses. And we don't need to work out all the details. We just need to show enough of how it could work that we get some buy-in. And if we can demonstrate that it's feasible and build a coalition of support among our legislators, then that gives us the best chance of continuing. Any questions on that before I move on to the next topic? So that's why the committees are ending. That's why we're trying to compress the work in the next few months and really sort of focus in and get this done. Okay. Next slide. It was brought up at the last meeting that we wanted to hold time on the agenda to talk about public input and our board meeting time and location. So since that meeting, our community communications and community engagement committee offered to change its meeting time to 4 to 6:30 p.m. once a month, starting in March, for more opportunity for public engagement. And then also Healthcare for All Oregon has offered to host a series of town halls. And the current plan for this board is to continue once a month meetings on the first Thursday from 9 to 12:30. All of our meetings are always virtual and recorded, but I will open it up now if people have questions or discussion about either public input or our meeting time and location. Go ahead, Mary.
Okay, since I brought this up
Mhm.
before, I just think I need to say that I am very happy with the Community Engagement Committee changing their time and giving opportunity. And I think that really kind of takes care of what I was trying to do, to say. was giving that opportunity. So I personally think, fine, let's keep going with our Thursday meetings, that people have them on their calendars, they're used to them. And I don't want to upset, and I know the board, you know, all board people have a lot of things going on. So I just kind of wanted to put a period on my, having worried about this.
Thank you. Go ahead, Amy.
I just wanted to clarify that when we're doing that, the kind of public sorry, testimony, thank you, tired, it will be between 5 and 6
Okay.
of that time, and then the last half hour is kind of for our committee to, like,
Respond, listen.
yeah, observe
Listen,
what we've
yeah.
heard, yeah, but the public meeting time will be between 5 and 6.
Thanks. Yeah, thanks for that clarification. Great. Any other discussion?
So, Michelle.
Go ahead, Michelle.
Thank you, Chair. I just wanted to acknowledge the CECC committee members and the staff. I am really excited to hear from the public as well, and just grateful that the committee voted to move the meeting time, and that staff is willing to support, even though it's outside of normal DCBS work hours. So just want to thank everyone involved for their deep commitment to creating more accessible community engagement opportunities. And if anyone is listening now or in the future in the recording, we would love to hear from you at between 5 and 6 p.m. And those meetings will be posted on the website. So please come and share with us. Thanks.
Typically meet the last Wednesday of the month,
The last Wednesday of the month, if anybody missed that.
except for
Great.
March, because of spring break, it's
Have you got it?
March 11th.
Great. But yes, all the meeting times will be posted on our website. Great. Thank you very much again to both of you, Michelle and Amy, for that. Go ahead, Chanwei.
This is just a quick both question and comment. I know the original budget and mission for this committee is for the engagement communication with selected targeted stakeholders. My question is, to what extent are we able, I know we may need more budget, are we able to engage the general public? Because one critical issue we don't have idea is what to the general public would be an acceptable range of tax. And that will be very vital. And my main concern is after all the work, I don't want our whole plan to sink because of the taxation. So we need to gauge what's our acceptable range of the tax.
Michelle, do you want to respond to that?
Thank you, Dr. Chi. It's a great question. It's something we've wrestled with a lot. And I would say a couple of things. One, this is one way that we're trying to hopefully increase more broad public engagement, creating an opportunity outside of work hours in the evening. We know it's not enough. It is something we can do. We're trying to be creative within our resource constraints, both in terms of money, staff support, staff capacity, and timeline. And one of the things that CECC is going to be discussing is what other creative methods can we work on within those resource constraints. We have compiled a robust list, so I think we can do some additional outreach now that we have more of a draft plan that we can send out for feedback. We also may come up with some other ideas that Amy and I will bring back to the board from CECC, but that is part of their work plan for these next few months, is to brainstorm what creative options we might have within our constraints. The second thing I'll say is, this is, as you heard from Dr. McDonald, this is something that we will be recommending in our report to the legislature, that they fund and direct a full public engagement effort. And that is a next phase of the work that I see as absolutely essential. And it is something we would need the legislature to invest in, because it would need to be significant. It would need to be well supported. It would need to be really comprehensive to meet what you're pointing out. And so I think that we'll do what we can now. And we're going to be working with CECC to brainstorm some options. And then we're going to recommend to the legislature that this next phase really is critical and needs to be funded and needs to happen. And so those are the two things that we're able to do. We've had some great proposals from the public. I know that Mike Huntington has sent us some proposals. Other people have sent some great brainstorms. that we can't do until the legislature invests in that next phase of work. So it's a yes and. We will do all that we can within our power. This is a first step, and we will recommend to the legislature that this has to be the next investment.
Be putting money for polling and.
Yeah, thanks, Michelle. Yeah, I want to underscore that as a reminder, this board has agreed that probably the earliest implementation of the universal health plan will be 2032, just for practical and logistic reasons. And so when we think about the work in 2027 to 2029, those 2 years and what needs to be funded, it's a lot of work around public engagement and what kind of taxes are feasible, as you alluded to, what people would be willing to accept, how it would be rolled out, as well as a much deeper investment in digging into the financial aspects of the plan. So again, the legislature, by creating this board and giving us a small budget and a small staff, has said, we think we might be interested, give us an idea of what this could look like. And now when we bring our proposal to them, it's to say, let's really put some state level commitment into this idea and make this happen. And then that broader investment, 2027, 2029 is where that work will happen. Go ahead, Mary.
I just have a question here. I'm looking at the agenda, and so are we in the board discussion
Yes.
time? Okay. Because one of the things that kind of serendipitously happened to me when I went to the legislature to testify on a healthcare safety bill that was at Senator Patterson's committee. He saw me and said, come up and how are things going? So I told her that, things are going, but this compression and this idea that we have to get this thing done and have this report submitted in September is feeling a little overwhelming to me. And I'm not sure, we're all doing our best to figure it out and wanting to be sure, remembering back to Governor Kotek's letter that was, it took a while to come. And basically, as I read it, kind of said, don't just give us a task force report again. We're spending money and we want to be sure that we're moving beyond it. And that's what I think we're trying to do. So when I said this to Senator Patterson, she said, well, do you need a little more time? And I said, well, I don't know how that would happen. I think it's in the bill and whatever. And she said, well, we could change that. We could move it if we needed to. And if you needed more time, kind of let us know. And I said, well, what would that entail? I do need another piece of legislation and they're in a short session right now. I don't know. And she said, no, she said, all you would need to do is come to my committee and ask, and I need to say it's okay and check with Representative Nose because it says that to report to these two committees. But she said, since it started in the Senate, she said, I'd like to be the one that would hear the request. And so I said, well, I'll take it back and see whether, we wouldn't have to use it if we could really get it done, but it might just take a little bit of the pressure because I'm really concerned about, as you say, these months of May and June and July are really, we're getting into the summer, we're getting into all of these kinds of things that happen. And so I just wanted to say that was a possibility that I hadn't thought was a possibility.
Right. Of course, it's possible for us to ask for an extension and to turn it in later. But as I mentioned, that time frame between September and December is our time to generate support, right? That we don't want to just turn this in and walk away, right? We got to turn it in. We've got to work with legislators and committees to try and make the case. The later we turn it in, the less likely it will be considered at all in the session, right? And so we would need to work with committees to think about how we would translate this into work in 2027, 29. That work takes time. And if we turn in the report later, then we miss that opportunity. Cheryl, I'll let you chime in here.
I just wanted to add on, I was going to say this in the Finance and Revenue Committee report, but most of our committee members on the Finance and Revenue Committee preferred a later report date, like December 2. With my work hat on, I feel really concerned about that because I know what it takes to get a huge bill like this through the long session. And it takes months of work, and you have to have a legislative concept, pretty much a good outline of it in September or so. So we need to be, and I realize there are people working on it already after this short session, but the board needs to be involved, I would say, in that legislative concept. So I'm concerned about pushing it back to December personally.
So if we were to delay until December, what would you predict would be the result of that, like in terms of getting airtime? in
I
the
think it'd be
session?
really, really difficult.
To get any
Because this
airtime.
is a huge, I mean, this is a fundamental change in the healthcare system.
Right.
So I do think we need to socialize it with legislators. I think it'll take some convincing, and I realize we have advocates who are doing that. I do think the board needs to be involved, though. We can't just be like, okay, here's our report, and we're not doing any of that work. So we will have to be involved in talking to the key legislative leaders. As you know, at least from what we've been told, 27 is going to be a terrible budget year because of HR1. I mean, we're kind of heading towards a fiscal cliff. And so it's all the more important for us to start early and talk to legislators about how important this legislation is. We're going to have to talk to Ways and Means co-chairs, you know, people like that who actually have the purse strings. So, yeah. So personally, I do not want to wait until December.
I will also reiterate that, you know, Judy and I and Mimi and the staff have really thought this through. And we feel very confident that we can get a solid report together and turned in by September. We don't feel there's any need to extend the time because we've laid out the work that needs to happen and it can be done. And it would give us a lot of advantage to turn it in September to, as Cheryl said, to give us that time to build support for it. Go ahead, John.
In considering the time constraint, we probably also need to be strategic to think carefully about what our final product, I call it a playbook, should be prioritized. And one option I envision is our final product we submitted to the legislature could be something looks like a draft bill. Because eventually, if the legislature approves, they will have to vote into the whole bill. That whole bill doesn't need to include too much detail, but important structures such as tax rate, such as global budget, such as the administrative structures. Right? These should be in there and eventually will become law when this is passed. So I think we should be strategic about what are the top priority we should develop by September. And Taiwan is an example. Taiwan put the whole national health insurance into law. And in the law, it only identified those key principles, the example I just gave. And then in terms of implementation, they develop further detail for the implementation, following in the spirit of the law.
Agree.
Go ahead, Mike.
I totally get both perspectives, right? And I'm trying to figure out, my intention here is not to cut the baby in half, but is there a reasonable position? And I'm naive about this, but between September 15th and first week in November, the focus is not on an election, right? So I can certainly defend doing the thing in September, but I don't know, unless it becomes an election issue, how this is going to get any hearing. So that kind of doesn't make sense to me. But likewise, I also know, having been a part of many successful and many failed efforts, that that it's very good for us to be focusing as if we're going to finish all this stuff by September, because otherwise we could keep deferring things. So I see both of us. Is there a possible compromise position to genuinely attempt to get this through September, but ask for an extension just in case we need it. for 60 days, something, yeah, yeah.
October, I don't know.
Yeah.
Just-
I would say that this board has hired Mimi to organize our work plan and our timeline and her budget. That's literally her job. That's what's in her job description. And I would say that if we get to that point in the summer and we feel like we won't be ready by September, we certainly would ask Mimi to come back to the board and propose an extension of our timeline. I don't think we need to make that decision today. I think we can see how the work proceeds in the next few months. And then Mimi can, let us know if she thinks we're not gonna get there, but at this moment, it looks like we're gonna get there, so we don't need to do that.
Yeah, I'm really fine with that if we have that flexibility. I mean, you know, Judy and I have not yet spent time, let alone meeting with the transition committee and this expectation that somehow many decisions that have basically been deferred for a year and a half, all of a sudden you're gonna do magic in the transition committee in a couple of months, you know, that doesn't seem to be a very sound assumption, so, but I'm sure we'll be able to do something within the transition committee, but I would certainly appreciate if we needed that. For instance, we needed that for certain pieces regarding pharmaceuticals, certain pieces regarding IT. The tax issue thing is enormous, right? And I don't feel yet that we've done our work, and that really isn't the charge for the transition committee. That really is did we get the finance committee and the benefit committee to agree on really what's a realistic package. So I'm very hopeful we could do what you're saying, but if we have the flexibility to move that out only if we need it, I'm not trying to break, the baby in half here, but it seems to me that we do all this planning and then life happens. I'm not quite sure we're going to be able to get all of that transition work done. I'm sure we're going to be able to do kind of a minimal amount and do the basics. What I'm not sure about is I think we have a major financing and tax issue that's got to be dealt with by reducing the cost structure and benefit of this plan. And I'm not sure that a couple of months is enough time to do that.
Right, so that's what we're hoping to dive into today, is the expenditures, and then that's the work of the board, not the committees, to reconcile the recommendations of finance and revenue and plan design. That's our work as a board, and that's what we need to tackle March, April, May, and get that sorted out. So yes, that's where we're gonna turn our focus next. I want to also comment that part of the reason why people have been advocating for the committees to continue longer is because we have incredible expertise on our committees. We are so grateful and so lucky to have so many participants on this board's committees who have offered their time and their knowledge and contributed to our process. And just because the committees are ending doesn't mean that we no longer need their expertise or won't tap into it, right? There are many opportunities for those experts to still be involved in our process, to participate in our board meetings, to submit public comment on their own. We can request them to submit public comment on specific topics that we need their advice on. These are folks who are clearly dedicated to our cause and dedicated to this board, and they will still have many opportunities to be involved, even though the actual structure of the committee meetings has gone away. So we are not cutting them off from participation. I want to make that clear. We still really value their time and their expertise, and there's lots of ways that we will still be able to engage with them. Any other thoughts or comments? Go ahead. Oh, sorry, you mentioned.
It's okay. Just a thought that as we kind of are going into this next phase of work, which will involve the legislative process and all of that, maybe if there's a way that we are tracking that, like collectively as a board, like looking at the September and December legislative days, and what does that mean, and what is our strategy? And it seems like in the past, kind of the board, the chair and vice chair have done printouts and all that, but the rest of the board has not really been involved. And it seems, I mean,
Being reported to the legislature?
Yeah.
Okay.
I mean, and not that we have to all be there, I'm not saying that, but just like, it seems like it's time for us all to kind of be involved in the strategy of that, and kind of, so I don't know if it's like a standing agenda item, but just also everybody being aware of what those important dates on the calendar are, because I don't know if all of us are involved with the legislature at the same level. So.
Yeah, no, it's, thank you for bringing it up. On the previous slide around the work before September, it's a legislative strategy is on there. And that's exactly what I was hoping the book to talk about, is how do we want to approach that? So yes, thank you for bringing that up. Go ahead, Jonathan.
I have a question, asking the board to think whether this is feasible and desirable. In terms of terminating the several existing committee, where we have committee member and experts who have a strong desire to continue to contribute, is it feasible for the transition committee to invite a few of those current committee members who desire to continue to contribute, to invite them into the transition committee? Because one of the big tasks is to reconcile the revenue expenditure and benefit. So I don't know whether that will be feasible.
Yes, we've already done it.
Already done.
Yes. Yep, exactly what we were thinking too, that the folks who have been involved all along the way will continue to be involved as part of the transition committee. Yeah, absolutely. Cool. Anyone else? Did I miss anything? Okay, let's move on. We've got a long discussion ahead of us about expenditure review. So I will turn it over to me.
So it said there's a vote in that last section.
So potential vote, we're required to notify the public if there's a potential vote, and I wanted to leave it open in case there was a vote about our meeting time or our meeting location, but it sounds like there's not. So
Just a process issue. There was going to be, at least I thought, a vote on from the F&R committee. Is that coming later or is this?
I was going to put that forward during our Finance and Revenue Committee report. Yeah.
Okay, great. Thanks.
All right. Well, thanks, everyone. So with the exceptional help from our team at Milliman, and I have them here on board with us, thank goodness for help. What I'm proposing to do now is a review of the expenditures that have been developed by Milliman. Some of the information has come in via various committees, and what we're doing here is really synthesizing it, giving the board an opportunity to look at it again. And the way that I've framed this up, and again, with the use of Milliman's information and their slides, they're credited in all of them, and there's links to all of their original slides. And as I said, they're also here. The way that I framed it is we are going to look first at how the Optimus report projected what would be happening in 2026, comparing that to what Milliman is projected. And those are the status quo projections. And then, so we'll look both at enrollment and cost projections. And then we are going to look at the healthcare cost trend assumptions that take this work from the expenditure work from 2026 to 2032 and understand how, the multiple factors involved in that, looking then also at the specifics of a universal health plan cost impact. Now, this is, I will say, what we are looking at, this is not the part of a universal health plan that is going to show a tremendous amount of savings. So we're not looking at the administrative savings. We're not I just want people to be clear. We know those exist, and we're absolutely going to talk more about those later. But so when the numbers look a little bit perhaps bigger than people want, I want people to understand why we're doing that. And then, of course, looking at opportunities that we can look at and really can put into our report in a very, very well-researched and rigorous fashion, so that we can then, when we make our ultimate proposal, there is very clear understanding where the expenditure figures came from and what we're using to potentially change them. So the Milliman work that we have, which has been excellent, is really a baseline data source. And I want people to think about that. Milliman has not made a proposal that this is the way this will be worked out. That is the work of this board. And I just wanted to be clear about that. Yes.
Just two clarifications. So when we talk about status quo projections, we're talking about projecting expenditures if nothing changed, if the universal health plan doesn't exist. So we have to understand what will we expect normally without any changes. That's what we're calling status quo. And then that's what we're going to compare to what would happen under a universal health plan. And yeah, just underscoring what Mimi said, that we figured out expenditures separately for actual medical expenses, actual spending money on delivering healthcare, those are the expenditures we're gonna take a look at now. They calculated administrative costs separately, and those will show up later in the slides, but the first set of slides are only about spending money for healthcare, not on administering the program.
Absolutely. And so this is taken from the Milliman, from their Finance and Revenue Committee presentation in February of this year, just so people can understand, just as Helen was talking about, how this was all developed. So there was a baseline population and expenditures from data from 2023, 2024, and then a cost trend, population growth, and one-time impacts were implied to get to this 2026 checkpoint, which is going to be compared to Optimist. Then, of course, there's an additional cost trend and more population growth getting into 2032. Then we have, again, that universal health plan impact of an expansion of benefits over from what people have currently, the potential for some other things which may increase total costs, such as adverse selection, induced utilization, and some other miscellaneous costs. So. All right, so I want to go through this relatively swiftly, but if you look at actually the enrollment estimates, and these are by various markets. So on the left-hand side, so you can see when there is public, that means, for example, HEB or OEB. When you look at the employer, we're thinking about insurance paid by someone's employer. Individual would be people purchasing insurance on an exchange, Medicaid, Medicare, and then we have the number of uninsured. And so what you'll notice in these 2026 estimates, the Milliman baseline came out at about 4.2 million. Optimist did a pretty good job at estimating the number of people who would be enrolled, also about 4.2 million. One thing that I want people to understand, maybe a little bit into the weeds a little bit, but the Medicare population does include people who are eligible for Medicare and those who are eligible for Medicare and Medicaid as well. People are sometimes referred to as being dual eligible. So again, just so people can kind of understand the difference. I think some things that you might notice a discrepancy if you look at the line that says employer. The Optimist report had approximately 1.3 million people receiving insurance from an employer, and it's actually the Milliman estimate is down to under 1 million. All right. And then you can also, if you look on the right-hand side, I think it gives kind of a better sense of like, all right, in terms of those sort of referred to as markets, where are most people getting their healthcare insurance from? And you can see essentially between Medicare and Medicaid, that already makes up the majority of the market. So we'll go on. So this again, 2026 enrollment estimate. All right, buckle up because these ones would get a little bit much. These are the expenditure estimates. And again, this is, we're just looking, the costs were built from 2023, up to 2025 data for the Milliman one. This is allowed claims. So in other words, just money that was paid to have healthcare delivered. And what you will notice as we're looking at this, if people aren't familiar with this, per member per month or PMPM basis, I think is kind of a helpful thing to look at. So if you look on this column here on the per member per month basis, you'll actually notice, and there's some rationale behind this, that for the most part, the Milliman estimate is actually a little bit lower on the Milliman side versus the Optimist projections. Again, this is for 2026, and you can also notice that by the percentage difference on the other column over there. And then you can also look at the total expenditures. And those are the other couple notes, the costs are lower relative to the Optimist projections on a per member per month basis. However, when you get to the total costs, and we'll see that in just a second, it's offset by increases in the overall population and also a change in the market. Because again, you can see that some members of the population, their baseline healthcare needs are lower than some others. All right. Please.
Oh, go ahead, Joe.
this may have been explained in the Finance and Revenue Committee, I just don't remember why the Medicaid baseline is so much lower than Optimus. Is that with Medicaid expansion population?
No, that's a great question. And if you look, if the second, I was just gonna get to that second sort of little asterisk down there, note, this table excludes certain items such as out-of-pocket behavioral health, unreimbursed Medicaid, and also excludes dental, vision, fertility, or dental and vision, not necessarily fertility, but so those were, because those types of claims are a little bit easier to be understood when they're taken out and then put back, but that's one of the
Oh, I
reasons why
see.
there's a big
Okay.
difference too.
Got it.
Because those are included in the Optimus, but not in the Milliman.
Can I-
Oh, and Ken raised his hand too. Thanks. Hey, Ken, I want to jump in. Thank you, Ken. Please phone a friend anytime.
Yeah, Fritz is jumping in too, but it's LTSS is really the big driver there.
Oh, Ken.
Because the LTSS is over $300 PMPM. So removal of the LTS is the big.
Yeah.
Long-term services.
Long-term services, right. Sorry, thank you. Yeah, long-term services and supports, if people didn't hear that. Thank you.
Yeah, and to also be clear, that's the cost of those supports and services, not any medical or prescription drug costs for those members. It's just the cost of those long-term services and supports.
And Helen?
So,
So it was.
Yeah, so-
We're not included.
yeah, so as a reminder, that when the task force contracted with Optimus, their overall prediction is that we could spend $1 billion less and cover everybody, and actually save money. And the data source that Optimus used to make that prediction is different than the data source that Milliman uses. So Optimus used less specific data. Milliman used actual financial reports and then backed it up with APAC, the All Payer All Claims database. And so when they were trying to compare apples to apples, what they realized is that, you know, the public and the employer-based health plans don't cover long-term services and supports. And they sometimes cover vision and dental and sometimes don't. And so if we want an apples to apples comparison, they took that out of Medicaid so that we could look apples to apples and see what is the per member per month spending on each of those things. It doesn't mean we're not going to pay for those things or that they're not covered. It's just to get a side-by-side comparison that was equal. And then the estimates that Optimus came up with were really different in terms of market share, in terms of Medicaid and Medicare, how many people would actually be in those markets. And that accounts for some of the differences. And so, yeah, this first bullet point that Milliman actually estimated lower costs on a per member per month basis for every market. But they had a really different projection in terms of how many people would be in each market, which means that overall, the estimated expenditures are much higher in the Milliman estimates than they are in the Optimus estimates. Did I get that right, Ken? Ken, are you still there?
Yep. And I see Fritz coming off mute as well.
Yeah, I would add that on this slide, one of the big differences here, and you touched on this, that the Optimus report basically started with all-in costs, which would include claim costs and administrative costs. So they looked at the system as a whole with all of the costs together, almost like an insurance premium, right? That covers claims and admin. So they looked at everything and then they made increments off of this for the changes that they think would be applicable under a UHP. Our approach was different. We built up our claims costs separately, and then we have another Milliman team that added on the admin so that we come to a total UHP cost. What you're seeing here on the slide is, you'll notice the title, it says allowed claims. Okay, allowed claims does not include the admin piece yet. It gets added later, but that's one of the reasons why this is lower, is that when we had really no way of breaking out of the Optimus report sort of what those pieces were. So what we wanted to do on this slide is just say, okay, here's how we did it, here's how they did it, let's compare them. We know they're different and we know why they're different. So there is the admin, and when we talk about admin, that is the piece that the administration that is associated with running the UHP, not providers admin or anything else, just the admin that is associated with running the UHP. So hopefully that helps. That's one of the so the LTSS on this middle column here is lower. That's why, we already talked about that, why that's lower. The rest of those are uniformly lower for various reasons. One of them, the main one, is that it does not include the admin piece.
All right, I'm gonna keep us going on, and Ken and Fritz, yeah, please jump in at any moment. And just as Helen was discussing, one of the things that Milliman is doing is this projection of how people will be, the population in each of those sort of market spaces. And so as we look, so we already saw the enrollment now, and now these are the Milliman estimates that we have in 2026. And we look at the population growth. And you will notice the increase, the one that I circled is in the Medicare population. If we move forward now we're gonna project into 2032, there's projected to be an 8.6% increase in that population. So, which is a significant increase compared to other populations. As you may have noticed, generally speaking, people in the Medicare population have higher healthcare costs than others. There was this is, again, these numbers are the Medicaid market will be impacted by HR1 also beginning in 2027. So the other thing that I think is important to call out is if you notice that the number of uninsured will go up substantially, or is estimated to go up in 2032.
Can I ask a question?
Yes.
Okay, so the Medicare, I understand, okay. And so the 2026 enrollment is slightly over 1 million Medicare. And then the status, okay, I see, I didn't read far enough along on the uninsured because I'm going with HR1.
Yeah.
We're gonna have a huge increase in that number of uninsured folks. So, thank you. From 122 to 348. Yeah, so thousands. All right, thank you.
All right, and now, so again, we have our populations, and now there's going to be this trend estimate assumption, which essentially says, so how much do we think healthcare costs are going to go up over that space of it? So the estimates that they have here, and Ken and Fritz, if you want to pop in and talk a little bit more about them, because this is a pretty, this is a pretty high level overview, but their low estimate is 5.3%, high estimate 7.4%. The Oregon, as people may be familiar with, the Oregon target is 3.4%. That's the Oregon cost growth target. Now, that's not one of the estimates that's been used because it's been is an underestimate. Yes, we've not had a lot of success about that. And this is, and as you can see there, that this estimate was not pulled out of a hat based on Oregon specific information and national health expenditure data. So. Right, I'm just looking at the questions, keep going. All right, so then what happened was there came a draft expenditures estimate summary. So, and I'll kind of go over this stepwise, but now, so we know our population, we know the estimate of approximately how much we think that cost is going to increase. And this is where you end up with these numbers. And again, these are expenditure projections in billions. You have the lower estimate of 66.6 and the higher one of 76.2. And that's of 4.4 membership in millions. All right. So kind of parsing this out a little bit more, you can see again how this number, there's the low trend at 5.3%. So these are the actual dollar amounts of per member per month, and going up to the 2032 numbers. And I'm wondering, Ken or Fritz, if you want to talk about that column that says the factor, so the adjustment factor. So I think that might be beneficial.
Ken, go ahead. How about?
Yeah, sure. So when starting from 2026, there's a number of changes, general changes that we expect other than just trend. Things such as prescription drug changes, new drugs that are coming in the pipeline, how we expect GLP-1s to impact things, different legislative changes, most of so that 2026 allowed, obviously we don't have 2026 information yet, so it's based off of 2023, 2024. So there's different legislative changes that have already occurred, insulin cap, gender affirming care. So it's items of that nature that we need that we expect to influence the 2032 cost estimate.
All right, so again, just kind of in a little bit of a different form, if we're looking at this, so we had the Milliman status quo, if we're taking the sort of pessimistic view, we have the status quo, the high scenario. Now we're going to talk about the impacts of a universal health plan. So on the upper right, kind of where those boxes are, it says PED Plus. So that means that all of the benefits that are available for people who are in a essentially a public employee benefit plan, with the additional of some other things, including essentially enhanced behavioral health and some other things that are described in a different place. There is induced utilization for people who have not had access to healthcare, or perhaps were very underinsured, and now have the ability to have coverage, and so they're actually getting the care that they need. There is the potential for people who live in different states to move to Oregon. So because they know now that some of their things that perhaps they're not getting their care they need in another state, they understand moving to the state of Oregon, now they will be able to receive that care. And then so that ends up with an even, a higher estimate. And I would say that our Milliman team has definitely gone over this in much more detail at the plan design and expenditure, and there's a link there for that presentation. Here's a little bit of the specifics around it. Milliman actually reduced what they thought the induced utilization would be based upon feedback from plan design and expenditure committee members, recognizing that the capacity in Oregon, although the demand may be there and people may actually have the financial backing, but there just may not be the capacity with physician services and other practitioner services and facilities, other providers being able to do that. So that is why you'll notice that in sort of round one, they had a higher induced utilization estimate, and then both for low and high, they lowered that estimate. Other things, again, talking about the adverse selection, there's a little bit more information about this. And again, this is an estimate. There certainly can be more, because we've had public comment that perhaps this estimate is a little bit high, and that certainly can be things that can be researched further. And then this, I think, is a very, very helpful table. This is something that talks about the very specific benefits, as we're talking about those sort of PEB plus benefits, and breaks out in billions the additional cost. So I see that Amy has
On this slide back,
yes.
one of the middle bullet. I wanted to better understand this adverse selection with the migration of long-term services and support users.
Yes, I will ask either Fritz or Ken, do you mind just talking a little bit about that? I mean, I sort of touched upon that people might move into a state where they might be able to have a higher level.
Yeah, I just wanted to understand kind of the whole, because we backed it out of those numbers, long-term services and support in the previous slides.
Yeah. I think I can answer your question. So that bullet point is a little bit kind of contextual when it's based on an adjustment. So the way we did the adverse selection is we looked at both people who live nearby, and we looked at more like chronic conditions and the populations that are more likely to move. And when we did our initial estimate, the round one, 2.4 to 3.5 billion. We did not include any people who would be LTSS users. And it was the PD&E committee brought up that, hey, that type of migration is likely. So it's a small, that specific population that we estimated moving into Oregon in 2032 is small, but we did just want to acknowledge that it made sense to us to at least include a small amount of migration. But the costs that would be included in this 1.3 to 2.4 billion would just be the medical and prescription drug costs again. Does that answer your question?
Yeah, I think I. Okay, so the previous slide where we took it out is just so that we can do like a more accurate comparison of like, of the Medicaid population to the other populations that don't cover it. So we had to pull it out so that we get a better apples to apples, but we've moved on now. Now, these slides are talking about what do we anticipate the universal health plan will cost? We're just trying to figure that out. So Mimi, if you can go back a couple slides.
Yeah.
Hang on, I'll show you. Go back a couple slides, right there. Oh, that one. This one? Nope,
The
actually,
colorful one.
Oh, this one, sorry.
Okay.
There we go.
there, this one. Right, so basically the purple circle, if we do nothing and don't have a universal health plan, things are gonna cost about $76 billion. And these are just medical expenditures. And if we do the universal health plan, it's gonna cost $87 billion. So basically, we're gonna increase the cost of just paying for healthcare services by $11 billion by just doing the UHP. That's the main point, that it's gonna cost more to do UHP than it currently costs to provide health services. And the reason is because we are giving people a better benefit package, the PEB level benefits, and that's more than some people have right now. That we anticipate that people will use more healthcare than they currently do if there's no out-of-pocket costs, that they've been delaying or avoiding care because of costs. And so that's the induced utilization, and that some people may move here because of the universal health plan. The following slides after this kind of show like kind of where those came from. Oh, and then also the last box is that we would be covering all these uninsured. So that's why it's going to cost $11 billion more to do the universal health plan than to maintain the status quo. And so these are estimates. Nobody has any idea what's going to happen, right? So like we're just giving our rough estimates. But basically the idea with this adverse selection estimate is they reduce this. It's not as high as they originally were projecting, but there is some thought that folks who have a lot of healthcare needs might be more inclined to move here because of the UHP than folks who don't have many healthcare needs. That's an assumption and a guess, and it's been reduced from their initial guess, but we just don't know what's going to happen. We just want to account for some of
And
that.
my question might be more for on the plan design side, but I've lost track of where we are with long-term services
Yes.
and supports.
We're-
And because there was gonna be a work group and then that didn't happen.
Right. So so the long-term services supports the plan design and expenditures agreed to pull it out of the universal health plan and say that universal health plan is not going to cover any long-term services and supports per se, but there will be a different mechanism for covering them. And
So
you're right, there
maybe
was.
still managed through disability services or.
Right, so we are working on a proposal for that, and that's part of the work that PD&E will present to this board after our March meeting. So that's coming up for us in PD&E in March, is kind of a final sort of reckoning about long-term services and supports. We don't have a work group for it. We didn't have the bandwidth to initiate another work group, but we have fantastic staff and research going on behind to put together like what it could.
I would like to be.
Yeah, so, but right now, the plan design has recommended that long-term service supports not be covered under a universal health plan and instead,
I mean,
pay for
we're
it.
in a period where reinstitutionalization of disabled people is happening at all the levels. You know, our state just, a budget proposal is cutting 2,300 disabled kids off right now in this legislative session, so.
Right. So this is a great example of what I mean by, we need to get through this expenditure project, report and understand where these numbers come from so that we know what we're dealing with. And then in the coming months, in March, April, May, we need to do all of this reconciliation work. Is that really what we want to do? Do we want long-term services here or not? Or should we put it back in? Or how do we reconcile the benefits with the expenditures? Or with the revenue, right? And so those are the kind of discussions that this board needs to dive deep into. We don't have time to get into it today, but we need to dive into it in the coming months to figure out what we should be paying for and what we shouldn't, because these numbers are really difficult to reckon with. Yes, go ahead, Mary.
I guess I just want to reiterate what was said and make sure that we're understanding that long-term services and supports, the part that was pulled out was really more the institutional part or, nursing home kind of
But it
That's
also
not
includes
in
a
there.
clinic there,
Yes, okay,
which keeps people there.
I got that, okay, but I'm saying that's what got pulled out, but what's in here are the fact that if they need a prescription,
Yes,
or they need to go to
Medical
the
care,
doctor tomorrow.
absolutely, or be in the
Those-
hospital,
Right, those
Absolutely.
things are in here,
those are in.
but the other parts, at this point, we
Right.
said, and I think
Caregivers.
what we said before
Right.
was that we would have that continue
Yes,
the way it is now, and now is changing, I hear you, but anyway, I just wanted to
Yes,
make
yes,
sure
yes.
I had that clear.
yes.
Okay,
that's
thank you.
Yes, I don't know who's, go ahead, Stephanie.
I have a quick question about the projection for the universal healthcare costs. Does that include the administrative cost saving? So for example, under universal healthcare, based on a few previous study and estimation, under universal healthcare, hospitals and group practice, they can cut 90% of their full-time staff who are doing billings. They only need about 10% of what they currently hire. So that would be a big administrative savings. That's not incorporated, I assume.
Right, right, so what Milliman did is just look at the actual expenditures for healthcare and they weren't able to estimate, but that's again, when we do reconciliation, that is something for us to consider or to recommend further research into or projections. We need somebody to make projections about the savings out, but that's not what this is. This is just spending money to deliver healthcare services. Yeah, go ahead, Cheryl.
Behavioral health is a relatively small part of this expenditures pie, but I just wanted to mention, I said this in finance and revenue too to Milliman, but if they're using the funding from the 25-27 OHA budget for behavioral health, we need to carve out the institutional care and the funding for legal system involvement and that kind of thing, if we're not including it in the behavioral health proposals, what I'm looking at, so I can help with that, but I just wanted to know, it's not gonna change us very much.
Oh, and question on, I know we keep talking about adding dental and $3.3 billion money. Has the plan design and expenditure committee come up with what is that dental? I mean, is it like everything up through crowns and
It's what's
whatever?
covered under PEN, which is a basic dental service. Yes, and we can dive more into that. It's not everything, it's.
Which hopefully is better than the.
Yeah.
Right,
Anyway, I
it's
just-
PEB level, it's PEB level benefits.
PEP level, and I guess I've not had a adequate understanding, I guess, of what, especially dental. The PEP is.
Oh.
So, because people keep saying to me, well, boy, that's a lot of money, maybe we could cut back on dental or cut out dental or do something.
I would say this is a very basic dental package.
It is.
Yeah.
Okay.
Yeah. Dental's expensive, for sure.
All right. No, I'm very cognizant of the time, but I
Yeah.
think this is a really great discussion. I think
Yes.
that people are
Let's
hopefully
do,
having-
let's plan for just 10 more minutes, Mimi, and we'll try to.
Oh, yeah.
See.
I think we only have a couple more. All right, so, again, just moving forward, we went from the status quo estimates to now you have the UHP estimate low and the UHP estimate high. And again, you'll notice under the high estimate, there's a slight increase in the population. So here is a table that looks at benefits where Milliman has what the BE stands for their best estimate. This is where they think things are going to land between the low and the high, which is not too surprising. So what they have done, what they're calling the PEB plus benefits are that dental, vision, fertility, and some other benefits. That is that enhancement. Now, in this particular slide, you'll notice the big green circle up top. This is when administrative costs have been added in. These are administrative costs of what we would consider sort of the health plan side of things. In other words, how do we get the cards to people and make sure that the billing all happens, all the things. So these are not the provider side costs. This is really the cost of administering a plan. You'll notice under the low estimate, a total administrative cost of 4.6 is actually very low, which is considered what some other so let's say a commercial plan would certainly be higher than that. So just so people, again, have a sense of where these numbers all come from. And also the ability, if you took away some of those benefits, what might that look like? And now we're going to also talk about just exactly that. What would it look like if those benefits were not there. So that's under the, now they're called lean benefits. Actually, it's still an excellent benefit package, but it is without that dental, vision, fertility and other benefits. So you'll notice there's lower. There is also, again, this is just what it might look like if there were to be some specific types of cost sharing. This is not a recommendation on behalf of Milliman or the board. They're just numbers that can be evaluated in terms of this. And then there are also potential administrative cost savings. So again, just so people have an understanding now. So now what we're looking at is really this full benefit package. And then what is called the lean benefit. So again, just wanting to make sure everyone's clear on that, why there's a difference. And the magnitude of the difference. Obviously, we're talking in billions here, so it is very broad.
So can we just point out then with that slide that it's up to the board to have this discussion, but if we decided as a board that, we could hold out vision, dental, fertility benefits, offer those as supplemental insurance that people could purchase separate from the UHP, that would save $7 billion. So best estimate cost with full benefits, 85.5, best estimates with those lean benefits, 78.5. So $7 billion is vision, dental, and fertility care. And again, it's not that we wouldn't offer those, it's just that they would be available through supplemental insurance. And of course, folks who qualify for Medicaid for whatever reason would always qualify for vision and dental under that plan, under the UHP, because we're not taking away benefits from anyone. So if they qualify under Medicaid, they would still be covered, but it would just be removing it as the PEP plus benefits for everyone.
I'm struggling, I guess, with how we'll be making these decisions prior to a really deep analysis on the administrative savings of a universal health plan model. Because it feels like we haven't even gone there yet, but we're already talking about cutting benefits.
So Milliman can only use data that exists. And we don't have data on what a universal health plan what kind of administrative savings would result from a universal health plan in the US. We don't have that data. It doesn't exist, right? So they're giving us data estimates based on data that they can build off of, that they know is accurate. We're going to have to make some assumptions as a board about administrative savings because we don't have any real world experience
So there were
in that
no
model.
consultants.
No.
Sorry.
Can I interject with this? So there's a couple things that I'll let Ken speak in here too. There is the Milliman team that looked at the administrative side. They actually do have that part, the administrative side savings actually are built into their administrative estimates, and we can go over that in more detail. Now, I think what you're alluding to, which I agree is still going to be part of the conversation, is what is the potential for even more estimates, just as Dr. Shi was talking about the incredible savings that might happen at the level of a provider because they don't need,
Yes.
billing in their hospital. So I'm very fortunate that we're going to actually be able to work with Dr. James Kahn, who has done a lot of work in California, and some people are familiar with him, who has done tremendous amount of work and has offered to be able to do some of those cost saving estimates with us. So we're going to have our Milliman data set point. And again, they do have some very accurate health plan I keep referring to it as health plan, sorry, but that kind of side of things, administrative savings. But then we are also going to have these projections of the types of savings on the provider side. And then there will be some other things too, and we'll get into that in a second. But what is the realm of possibility for really cutting costs when it comes to prescription drugs? So there are other things that are going to be built into it. But again, we're just trying to get these sort of building blocks in place.
And
So
I want
it's a
to be
great
clear
question.
that nobody's talking about cutting benefits, but because we have Milliman for limited time, we ask them to show us different numbers for different pockets. It's really hard to deal with one giant number, just say $85 billion, right? So
Yeah.
what goes into that and what are our options as a board? So we just wanted them to pull out some options for us while they could do that. Go ahead, Ken.
Yeah, I was just going to clarify that point a little bit too, that it's not the full savings of the $7 billion isn't all just the PEP plus. It's also that in that lean benefits, we added copay to ER co-pays to drugs too. So that's what that cost sharing is. So it's a little bit of that too. But again, that's not intended to be a recommendation, just intended to be a point of reference.
Thanks, Ken. All right. Again, this is just a very similar example, looking at the costs that are related to that Medicare eligible population versus the non-Medicare eligible population. Again, this is not a suggestion. Sorry, I made a little scrubby green mark here. This one, so people understand, like, wait, that number wasn't exactly the same as the other one. This one doesn't have the administrative costs in, just so when people are looking at their math and it's not mathing, that's why. So there's, it can be put back in, it just didn't have to be on this slide. This is what happens when you get things from a couple of slide decks. But again, just looking at, all right, so this is what the a Medicare eligible population in terms of it, as we know, it's this tends to have higher cost per person than non-Medicare eligible population, but that's all. It's not a recommendation. All right, this is the famous waterfall slides. We'll go over this one briefly. In other words, how did we get from the left-hand side all the way to the right? And what I will want to point out again, if you look at the far left, the Optimus 2026 report, and then if you, this is the comparison to that report, and then Milliman trended to 2032, that's the difference. When you see those numbers, this is the difference, not the total cost. So as you look at that 2.2 for the PED benefits, again, that's the difference compared to the Optimus estimate, excuse me, compared to the Milliman one, where we get, if we went all the way over to this full benefits for the entire population, and this includes the administrative cost, that's where we come up at that 85.5 billion. If it were to be the lean benefits, which again, this does include, not a suggestion, just in the numbers, some cost sharing, it lowers it by almost 7 billion subtotal lean benefits. And then if the Medicare population was not included immediately, it would look less than that. So again, just so people have a good understanding where we went from left to right. I don't see any questions right at the moment. This has been I think this slide has been very, very helpful. Oh, and Michelle, please.
This is helpful. Thank you. One question that I have is, is there a number? Do we have a number for what lean benefits looks like without cost sharing?
We can do that, just because I'm going to scroll back here. This is what the cost sharing is.
So you just, so you just
it's pulled out. You can just
manually.
subtract it out. Yeah.
Got
Yeah.
it. Thanks. I see those as kind of two levers we could pull. So it's a little confusing to have them bundled, but that's helpful.
Yes.
Yes, it's like 3.4 for the benefits, 3.4 billion for the benefits themselves, 3.6 billion worth of cost sharing, and together they come up to around 7 billion.
So yeah, great question. All right, sorry. And now this is just a list of opportunities. This is not exhaustive. It's certainly not detailed, but some of the things that are very evident, if there's a universal health plan, you know, providers frequently do not get all of the money that they bill for, right? So people are unable to pay. So providers would now get 100% collectability of their fees, which potentially could be translated into having providers paid at a different level, because they are guaranteed 100%. So they're actually, and they don't have the problem of trying to collect fees and all that administration costs related to that. Standardization of a fee schedule, billing simplification, contracting. So these are all the things that will lower the total cost. Certainly near and dear to the hearts of all practitioners, practitioner efficiency, streamlined quality measures, uniform requirements. There still may very well be needed prior authorizations, but they could be electronic, they could be built into they could be immediate in real time, etc. So again, we're not going to an exhaustive discussion around this, but this is even more to come. Phew, we made it to the end, and I don't want to take too much more time, but I think that what we really tried to do is walk this board, because this is where all the are going to be the decision makers about these important things, and to make sure people have a good foundational understanding. Yes, Mary Lynn.
Just a question. I'm not familiar with Dr. James Fund. at some point, Phil, you can give us.
Of course,
Some more information.
yes, and yes, you'll actually be able to present.
But it is that, okay.
Oh, I'm sorry.
To that point, I just wanted to ask you, because I know this will come up. I believe he's going to help us with the calculator.
He will also help with the calculator as well, because he is an incredible
hearing somebody
human
through the
being,
calculator.
that's KAHN.
Okay.
He's a professor emeritus at, I think UC San Francisco,
Okay.
and the economist extraordinaire. Richard knows him as well, so he
Yeah.
Oh, at Berkeley. Sorry. Now I'm gonna get in
Good.
trouble. Oh, no. Okay, I will. What do we wanna-
Does anyone have questions or items for discussion to start with? Because I wanted to just bring up one other point on.
Yep. Oh, and then there's some references back here. Yep, I'll go back to the discussion. Actually, I'm gonna stop sharing because I'm gonna pull up Dr. Cheese, so you go ahead and,
Oh, I need to find it.
Okay.
oh, you need a slide? Dear. What I get? Sorry. I'll go back. There we go. Which slide?
So, slide 20, Milliman slide 23. It's the low-high target with the trend, the 3.4,
Oh, the big,
the trend one that shows
this one?
trend, up or up. The low, medium, high trend,
Oh, okay. Sorry. I thought I-
circles,
oh,
Milliman, so.
sorry. This one.
That one, yeah. So in addition to like, kind of this, that it will cost $11 billion more than status quo to do a universal health plan. This slide is really important to me because it estimates medical trend, and that is the estimated increase in medical expenditures year over year. And these are based on really good data. So 5.3, somewhere between 5.3 and 7.4% is the increasing cost of medical services
As
each
is.
year, right? And so this number, right, but it's the actual spending on healthcare, and so it's gene therapy and it's cancer therapy and it's pharmaceuticals and it's right, it's the actual cost of medical care, not administrative. So this is medical trend, and so 5.3 to 7.4%. That is what we can anticipate that universal health plan budget will increase by once we get to the point where we have administrative simplification and we have, kind of a built-in system and we've accounted for the induced utilization. We still are going to have a trend, and we need to have a revenue strategy that keeps pace with trend, or we need to somehow affect this trend. So this slide is what I worry about the most about a universal health plan, because how are we going to manage the fact that our costs are going up 5 to 7% every year? There will be some built-in savings from the administrative simplification for sure, but it doesn't change the fact that labor costs go up and that pharmaceuticals get more expensive and that more innovative therapies are available and different, surgeries are available that people are going to want and need access to. And we need to understand that, like, when we start basing a payment for healthcare on mostly on personal income, that people's personal incomes don't increase this fast. The rate of, the payment, how people are, the increase in the growth in salaries, the growth in income and growth in salaries of most households doesn't go up by 5 to 7% a year. It goes up far less than that. And so if our revenue source is mostly based on income taxes, then the rate of growth of those income taxes and therefore the revenue for this plan is not going to keep pace with this current trend. Now, there's arguments to be made about how we could adjust that, but I just want us to keep this in mind and be very aware of that. We are not building a plan for 1 year where we have to get revenue and expenditures to match for 1 year. We got to build it indefinitely. And so we've got to accommodate for this trend, which is what has sunk many other efforts at state-based universal health plans, is this idea that we cannot come up with a revenue strategy that will keep pace with the growth in healthcare costs. That's what has sunk many efforts in other states. And so we need to really keep this front of mind. And I wanted to emphasize that.
Can I say?
Oh, yeah, go ahead, Mary.
But this trend in the past and in the current is just totally free market, totally, I mean, it is not everybody under intent at all. I mean, and I'm not talking just about administrative savings. I'm talking about, kind of setting price caps for various things, so that you don't have one hospital building 20,000 for hip surgery and somebody else building 40,000, and it both gets paid. or at some level it's made and gets all dumped into this. And so, yes, I hear you, but I also think that we're really talking a more socialized approach to all of this. And so we need to be thinking about what really can we project it. So, you know, and I can't remember now, but I do remember Charlie Swanson presenting something at the finance committee showing actually that incomes in the past have been higher than the cost trend in medical care, which is not what we keep hearing. And it was in Oregon. And so I don't know, Cheryl, can you
I
remember
do
that?
not remember
I
that.
can't remember, but at some point I'd like to get that one pulled out and find out where he got that, but it was over these past years. And he was actually showing that incomes did slightly increase more than medical cost trend. So I just would like to see
Yeah.
that piece, and I know he presented it somewhere. Somewhere I got it.
Right.
Can't pull it
So
out.
that's the kind of information we will need
Yeah.
from folks as we
Right.
start making some deliberations.
Yeah.
And then, so to your point, Mary Lou, which is excellent, is that one of the things that we can do, so we're going back to our stepping stones. I know there's been a lot of concern about those, but one of the ideas that we keep putting forth as a stepping stone is a standardized fee schedule. Is that leveling off of
Yeah.
what hospitals pay? Because part of the reason for trend is that commercial rates go up to compensate for low Medicaid rates or low Medicare rates. And so standardizing the fee schedule where everyone charges the same thing for a procedure regardless of payer is something that we could offer to the legislature as a stepping stone. It would need to be in place. It would start to bring this trend down, right? And it would get us a little bit closer. So when this board sort of puts forth ideas like that, it's with that in mind. It's this idea that there have to be systemic changes to how we think about how we pay for medical care. Short of a universal health plan, just how you think about doing those kind of cost shifting calculations so that we can bring this trend down so that it makes more sense to base the revenue on a personal income tax that is a more fixed rate of growth. Yeah, go ahead, Mike.
Well, briefly, Shumway and I were talking about this yesterday. And I had mentioned that, in all the years that I teach, global health and asking students, what are the things that actually make a big difference? They all tend to pick one thing, and that is exactly what you just said, which is until we standardize the prices, what we have is essentially a running on train. So I guess something for us to think about that we can't control, but obviously if we're going to be involved after submitting a plan, that we don't really have to wait 5 years until we do universal standard pricing.
Exactly.
And that may be one of the key factors that we need to look at. So I'm just basically saying, yes, what Helen said.
Yeah, that's exactly right. There are things that we could do before implementing this that we should do to kind of transition us in that direction that make a lot of sense. So, yeah. Okay, any other thoughts, discussion on this? We will continue to dive into this as we have with the revenue strategy when we do some reconciliation. Okay, so we have a presentation by Chunwei for coming up, but I'm wondering if we should do a break first and then come back and start on his presentation. Is that okay with everyone? Okay, so I have 10:43. Let's come back at 10:53, please, and then we'll start with topic. It's now reconvening. Please, I'm going to ask everyone to quiet down. We're going to reconvene now, and we're going to turn the mic over to Professor. We're going to reconvene the meeting now. I'm going to ask for silence in the room so that we can get started. We're going to have Isabel start the recording again. And then I'm going to turn it over to Chunwei to begin his presentation. Share.
Good morning. This is nearly noon. It is a great pleasure for me to share with you my experience in late November, attending two back-to-back international conferences in Taiwan. And these two international conferences both have a similar theme, celebrating the 30th anniversary of Taiwan's universal healthcare. So what I'm going to share with you, partly was my presentation in the second conference, but also partly the highlight I learned from many international professional scholars. So for example, it's a very rare event in the first bigger conference. Taiwan was able to invite several important scholar leaders, such as World Medical Association's Executive Director, European Medical Association Executive Director, and then the APHA Executive Director, as well as the World Alliance of Public Health Association. So all those important global leadership were in the same conference. So next slide. I included more slides than I can present. So some of the slides I will skip that just for your information because you will have access to those slides. So my presentation divided into 4 sections. Section 1, 2, and 4 were highlight of my presentation in one of the conference. Section 3, I summarized some important insight from those international scholars. Next. Next. So this is begin my part of my presentation. So a big question regarding how we treat health system is it an industry or a social institution? Next. So I developed this table to contrast what's the implication whether we treat health system as a social institution versus as an industry. So it will have a profound impact on how we see the nature of healthcare and how we treat people, whether they are citizens or consumers. And what will be the claim for people to use healthcare, whether it's a collective agency for member society or willingness to pay. And what will be the governance? And then finally, what will be the primary goal? Next. So in this second brief section, I highlighted some of the big achievements that can be a lesson for us, for Taiwan's universal healthcare. The first one is the role of information technology. We haven't spent much time talking about that. The information technology not only improve access to healthcare, but also improve quality of healthcare while reducing significantly the cost of healthcare. Next. So this is the process over the last 30 years, how Taiwan, step by step. So we don't need to expect we will be launched right at that point. It will be a phase in step by step. But we can skip many of the past steps Taiwan went through because that was before the current technology were available 30 years ago. Next. And this is the chart about how people satisfy. And the National Health Insurance Administration has been very sensitive to the public opinion and preference about the system. So since 1995, when it started, they track quarterly, 4 times a year, the public satisfaction. And you can see how the recent year, it steadily above 90%. Very few countries' healthcare system have that kind of level of public satisfaction. And there were a few dips, and highlighted in the chart, the few dips was when the tax was increased. but shortly, they go back again. Next. And this is one of the study published comparing all leading healthcare system. And Taiwan is an outlier on the far right up corner in terms of cost and quality. Next. And this was from last year's, from one of the magazine did an assessment about 7 top countries, and Taiwan again was number 1. Next. And this is financial status. I calculated the most updated data, not in this chart. Right now, they still have some surplus left. So they have made some adjustment, including cost control, as well as slow and small tax increases. Next. So this third section I will share with you some of the important highlight I learned from two conferences. The first one is the big one. They have been held every year, but every year has different theme. But last year happened to be the 30th anniversary. So this big conference where they invite all the leaderships from around the world was focusing on national health insurance because it's 30th anniversary. Next. So they had three keynote speakers. My graduate school advisor, Professor Xiao, was the first one. And I highlighted his assessment of Taiwan's universal health insurance systems. So he pointed out some of the fraud. The first major one was about the payment method and rates. And he's getting into the detail. I will not discuss those details. Next. So this is an important lesson that before the break, we talk about. He's concerned about how the system didn't take a longer term financing of the universal health systems. The consideration of the financing should aim at the long term, like 40, 50 years at least. Next. So he grouped his assessment. This is the last one. In terms of the governance of NHI, this is an area I've been doing research on. Taiwan, in terms of governance, is still inadequate, even though the National Health Insurance Administration is very, very sensitive to the public input. But they need to do more. But also Professor Xiao emphasized, how can we help the administration of the National Health Insurance shield from political maneuvers? And that's something we also have to be careful that there will be politicians who want to influence, not necessarily the whole system, but the subset of the system, whether it's about payment, about the budget, etc. Next. And he also summarized some of the major current problems in terms of there still some ways that can be improved, and the watching out for the budget deficit and quality. One of the big challenge that we are also facing is shortage of health professionals. And he also pointed out how can we improve that shortage of health professionals. Next. So this second part was from a professor in London School of Hygiene and Tropical Medicine, who was a former president of European Public Health Association and who is the current research chair of European Health Commissions. So in his presentation, we can look at the left dark shade part of the highlight, build capacity for crisis responses. And I particularly circled with the red, how can we foster political literacy, ethical negotiation, and system thinking? In other words, how can we facilitate the public political literacy, particularly related to health system and healthcare? This is what we need to do when we try to gauge how much people are willing to pay for tax. We cannot just ask them that simple question. We have to give them information, not just asking about the tax, but they have to know what they are trading off, what they are comparing. This is what Professor Maki talking about political literacy. Next. And this is also very important for us, institutionalized listening. And that communication is vital when we go into the community engagement, because particularly once we submit our plan to the legislature, we can imagine how those interest groups will en masse lobby. And then we need to inform our public and kind of give them a vaccine against disinformation and misinformation. And to build that vaccine, we need to be a good listeners to what other people's concern. And this is what Professor Maki emphasized. Next. And reframe health as a priority. Health should not be sidelined as a secondary importance, particularly even in the budget crisis. And I highlighted that public health must position health as a central to foreign policy, national security, and domestic resilience. So this is shift from health in all policy to health for all. Next. And another scholar, Joseph Cousin, he recently retired from WHO. WHO since 2000 had a big initiative continue to this day, universal health coverage. So if you're interested, you can go to WHO website and type in the universal health coverage. You will get a ton of information. So Mr. Cousin used to be the head of health system finance and the universal health coverage. And so he gave a lot of his insight about what's the universal health coverage trend. So for example, he talked about how revenues adaptation, not rigid model, is important. And he argued the emphasizing wage-based tax because of the concern with employment, etc. Also delinking entitlement from contribution. Next. And in his presentation, he included how mostly European countries start to have a mix of single and multiple funds. Even though the funds might be mixed in terms of the source, but the payment remain in most countries remain uniform. That means the finance part, the source, can be diversified, yet the payment part should be unified. Next. And this is my summary from his important talk. The system look different, but there is convergence towards single unified standard provider payment system. And at least among the European country, the voluntary health insurance is playing smaller and smaller role. Another highlight I pointed out, the financial protection for people with chronic illness is very important, as well as maintaining social solidarity, cohesion in light of challenge to historical political value, challenges and consensus. So as we move forward, besides concerning about financial sustainability, equally, if not more important, is political sustainability. Without political sustainability, no universal healthcare will sustain. And one of the very prominent scholars, I was very honored to meet him, Sir Andrew Dillon. He was the founding executive director of the British NICE, the National Institute of Clinical Excellence. So he was among the speakers invited. So he talked about the role of health technology assessment. And I highlighted one section, the clinical effectiveness, safety, costs, and economic implications, ethical, social, cultural, and legal issues. There are organizational and environmental aspects that can be taken into account. So it's not just technological, that all the entire social and ethical important consideration in health technology assessment. Next. And in his presentation, he discussed about the core method and processes of health technology assessment. And I highlighted three bullet points: assessment of social, ethical, and legal implications, and then also application of scientific and social value judgments. So it's a mix of positive and normative values. And transparent in decision-making are very important to the public. Next. And then towards the end of his speech, he talked about the future of health technology assessment. I highlighted the two last points: integration with managed access agencies and agreements, and also earlier engagement with innovations and patterns to align ambition, reduce costs, and accelerate access. That's the early engagement means the technology are still under development or in the early clinical trial. Next. So this is from a Taiwanese scholar who introduced about the Ministry of Health's a massive initiative incorporating One Health. And part of that is application of smart healthcare, incorporation of both information technology and AI in different aspects of health. So in Taiwan's universal healthcare, one uniqueness about that is its integration with population health promotion are seamless. And so this is just one example. Next. And I mentioned about taking climate crisis as an important issue of healthcare. And the speaker also identifies an important policy and strategies. I will not get into the detail, but you can look at that slide. By the way, most of their talk are available on the website. And also all their slides are publicly available. Next. And also part of the medical resilience response to disaster, that's something along the way, we may also want to consider how we make our health system resilience. Particularly Oregon is in a high risk of earthquake, such as those disasters. How do our system can adapt, can face, can respond to that? So this was all considered. And in the recent pandemic, Taiwan's universal healthcare performed very well. Again, seamless integration of healthcare with prevention control. Next. So this is the second conference that I presented. Also commemorate the 30th anniversary of National Health Research Institute. That's Taiwan's equivalent of NIH. Next. And our former Vice President, Dr. Chen, gave a keynote speech highlighting some of the challenge I earlier mentioned about shortage of workforce, and particularly not just shortage, but also retention issues and uneven geographical distribution. I think Oregon also faced that. Many, not even rural areas, smaller towns also facing severe shortage of providers. Next. And earlier I mentioned One Health has been a big initiative under the Ministry of Health, which the National Health Insurance Administration is part of it, and Taiwan's CDC is also part of it. So this chart shows how One Health is incorporated in Taiwan's public health and health system. Next. And one Taiwanese American, Professor Jason Wang, he's the Director of Health Policy Research at Stanford University Medical School. He was also an invited speaker on this second conference. And in his talk, he talked about how Taiwan used AI and information technology to connect health. When there are places or occasions difficult to have available in-person care, Taiwan supplement that with online care and supplemented with AI. Next. He also gave example of the British system also incorporated AI in assisting the NHS. Next. So this is my quick summary of important insight from two conferences. So first is there's a trade-off between long-term financial stability versus short-term public support. And then the second issue is community ownership is vital for governance and political sustainability. And the third one is health technology assessment is a vital system to promote equity, efficiency of a healthcare system, including cost control and improving quality and access. And the fourth one is integrating One Health and Health for All with technology to develop resilient health system. Again, we haven't spent much effort to think about how to make the system resilient, and that should be an important issue to keep in mind. And the last one is innovation and adaptation is key to resilient and equitable health system. Next. So the last part is also part of my presentation for this second conference. So I summarize their common goal of health system finance for universal health system. The top bullet point in blue are the common one, but I highlighted the bottom one. Income redistribution that serve as the equalizers for more equitable society. And that related to the last one. Health system represent the nature of a society. And we seldom think that the health system, one of the ultimate goal is to help contribute to a better society. Next. Of course, there are common challenges in universal health systems. The technical one, including quality improvement, cost control, how we improve access, governance, particularly how we institutionalize public engagement in governance. And lastly, health information technology and AI and other innovations. And there can be a mean, not an end, to achieve those four challenges. Next. But there are also political challenges. Number one is solidarity and sharing capacity. Professor Will Reinhardt said this very well. The issue of sustainability is the core issue of people's willingness to share. And then, of course, equity, efficiency, and then governance about who and how and what institution. Number five, that was from some of my mentors. How can we make our health system kind and friendly? The current private or market-oriented health system have been doing the opposite. I want our system to comfort the afflicted, but the current system tend to inflict the inflicted. And then the last one, we need more imaginations about how to adapt, how to evolve. Next. So I've been teaching health system for 3 decades. And one of the big questions I always ask students, what is the best health system? But that question is highly loaded because the best health system has to be qualified in at least 2 important critical questions. For who and in what? And one of the statement I always make say, I told my student, the United States has the world's best healthcare system and the worst healthcare system. So this confirmatory statement need to be qualified on for who. If you are among the top 1% or even 0.1%, US health system is the world's best for that group. But if you are the other 99%, unfortunately, the way we organize it is the worst possible system for the rest. Next. So that's a normative argument. So I spent a little bit of time to clarify this. The British philosopher David Hume has a famous statement. One cannot derive ought from is. Ought is the normative public policy. Is scientific evidence. Next. So I developed this chart, how scientists and policymakers often got confused. So we have 5 examples, 5 interventions, A, B, C, D. Each intervention can cure or prevent disease PQRS. So the scientist's role is to ascertain the causal relationship between intervention and outcome. So that part is science and belong to the public domain. But for the society, among PQRS disease, which one we target, which one we prioritize is no longer science. It's politics in the neutral sense, public affair, which is normative. So this illustrates the most frequent confused understanding and argument. And some of the misleading arguments were intentional, some were out of ignorance. So I want us to keep that in mind. just because you identify A can cure or prevent P doesn't mean that P should be our high priority, because there are others. Next. So I developed this chart to summarize the relationship between positive and normative argument. So choosing the health system's goal and priority belong to the normative domain. That's on the left side. And that require democratic governance and process. On the right-hand side, once the priority or goal already selected through that process, then how to achieve the health system's goal and priority become a positive sign, where the professional scientists have a role. Next. So finally, I share some of the important quote from several of my important mentors. Professor Evans, I invited him as keynote speaker in the first Universal Health International Conference I organized at OSU campus in 2018. And this is related to positive versus normative. He said a common way of building support for change and neutralizing opposition is to present the normative statement as if it were positive one. Next. So One Health is something we haven't thought about, but along the way, once we implemented the universal healthcare, that we should carefully consider how we incorporate, like Taiwan is currently doing, incorporate One Health into its health system. Next. So everybody is concerned about sustainability of health system. So I also developed this chart for that conference. So we have social goal and preferred distributive justice and associated allocated efficiency as the theoretical and ethical foundation. And that foundation will guide us in terms of political sustainability and financial sustainability. Together, they will shape and contribute to the sustainable and resilient health system. Next. And this is quote from a well-known health economist, Adam Williams. A healthcare system whose sole function is to ensure that the community is served, derives the maximum net benefit from its existence. This community wishes its healthcare system to be run in a manner which reflects the value of the community. Next. So in terms of the community and professionals' role, the community's value determine what shall be the health system's goal. Well, academic and professionals determine how we achieve that goal. Next. And this, I took this picture in 2015 when Taiwan celebrated 20th anniversary. Professor Reinhardt, I mentioned this, sustainability is actually a moral issue of defining the mutual obligation of the member of the community. Next. So in terms of resilience, again, we have to ask resilience for whom, for what, in what. And Professor Reinhardt actually has another famous quote. He said, without asking for whom, any system is sustainable. Without asking for whom, any system is sustainable. Next. To achieve resilience, we also need compassion, innovation, and adaptation. Next. So in concluding my presentation, I quote a famous Tang Dynasty poet. And that poet, I translated on the left. After searching for thousands of times, suddenly when I turned around, I found the one in a dimly lit corner. So this poem was used by arguably one of the greatest 20th century Chinese philosopher, Wang Guowei. So he proposed 3 phases toward transcendence. And the last phases toward transcendence is this stage, meaning after you identify the goal, whether it's universal healthcare or better health systems, and then you strive for it. So these are early phases. But to reach the top, you need to go through this one. That is oftentimes we neglected the important thing right around the dimly lit corner. So I asked, where is our dimly lit corner? Next. Another mentor of mine, Governor Monique, who inspired me about thinking healthcare system as a social institution. So this is a quote from his work, Healthcare as the Community Commodity. And it asks, what sort of healthcare system or system do we as a community prefer? Which translate to what sort of community would we prefer to live in? Next, the last one. Oh, not that one. Second to last. So as we continue to develop our universal health system, there are two types of relationship we need to pay attention. Too often we focus on the positive one, the causal relationship, which is unidirectional. But for universal health system, we also need to pay attention to the relational one. That is, how does the system encourage a more loving, caring relationship among our community? Next. So this is the last slide. So I present this in 2008 Oregon Health Forum. Healthcare system as a test of who we are. So is our healthcare system served to comfort or to inflict people, to enrich the society or oneself? And a society deserves the health system it has. This is an adaptation for a German proverb. Society deserves the political system it has. So I changed the political system to health system. So a national health system for us, our state health system, tell us about the nature of its people. Thank you.
Thank you, Chanwei. We have just a couple of minutes for questions, if anyone has a question. I have one small question and one big question.
Yes.
My small question, one of your key takeaways was de-emphasizing wage-based tax. And your key takeaways from the
Yes,
conferences in favor of what?
General income,
What do you
general
mean?
revenue.
From like the general operating budget of the,
Either way, either an income-based tax. For example, Taiwan Universal Healthcare started with payroll tax, but then it's been criticized as regressive because people who make really big income, they generally have little or no payroll. And so that part will let up and make the finance part regressive. So in about 2013, Taiwan amended the finance with capital gain and interest to capture that, not capture in the payroll tax. So this is what that means, to stay away from payroll alone. It doesn't mean we should not use payroll tax. The issue is payroll tax alone tend to be regressive.
the other question I want to ask you was, most of the presentation and then your points about it refer to sort of a cultural question, right? The
Yes.
cultural thinking of healthcare as a public utility versus an industry, of political sustainability being about solidarity and sharing capacity, about political priorities being relational, and about mutual obligation. Like that, those are cultural concepts. That means that we have to agree as a society
Yes.
that those things matter to us.
Yes, yes, but also the system can nudge on that. Let me give you an example. When I was doing my sabbatical leave, I spent 6 months as a full-time visiting researcher with the Bureau of National Health Insurance. And I was very glad and very proud I prevented a policy from implementing, because at that time, the National Health Insurance was considering giving rebate for people who didn't use any healthcare in a given year. I said that will erode the sharing willingness to share, because the National Health Insurance is a system to encourage willingness to share. But if you start to give people rebate for those who didn't use healthcare, you are pitting healthy people against unhealthy people. So that's one example that we have to be careful in any of the policy whether our policy enhance the sense of community and sharing, or we discourage the sense of community and sharing.
A little chicken and egg though, isn't it? Because like, you have to have that sense of community in order to be willing to institute such a policy, and then the policy can continue to further that.
Yeah,
goal.
but the policy can have influence on that.
Yeah, absolutely, absolutely.
And I think the question you're asking, Helen, is what is the state of Oregon in terms of, do we have a cultural belief or not that we are a sharing, caring community? Or are we individualistic fighting against each other?
And that we're willing to end the system of healthcare as an industry in favor of a healthcare system as a public good or public
Yes.
commodity.
As a social
And that-
institution.
That's the question that we need to sort of really wrestle with,
Right.
and that's like a big communications problem.
Right, I would
Right.
think that the people in this room.
Well, of course, the people in this room.
But it's, but it's not.
We don't run things.
No. But I think we are doing something that is going to be seen as trying to run things, I mean, at least move it that way. And so, you know, I just think we have a responsibility to try to figure out, how do we, as, you know, keeps getting quoted by various political folks, but the better angels in people.
Yeah.
And how do we bring that out in Oregon? Because I think that there is a testament that there are a lot of people who really do think this way, and how to tap into that and make it.
So it's a topic I'm hoping we can spend more time on as a board, and actually Judy has offered to give us sort of an overview of like what it might take to build a healthcare as a public utility. So one of our future board meetings, that whole topic of that sort of cultural value base that has to undermine a universal health plan,
And how to
and
get
is
there.
something that we'd like to spend more time talking about. Go ahead, Amy.
My comment was just, I really appreciate you highlighting that, Dr. Chinway. And I think that something that is unsaid, but every time this country has tried nationally, this country's basis rooted in institutional racism and ableism has gotten away. And it is integrated in our current healthcare system, those things, and we to.
Right, that's part of the idea, is like, we need to have,
And we have to acknowledge that to get to that.
yeah.
Public.
Michelle?
Thank you, Chair, and thank you, Dr. Chi, for the presentation. I did note the importance of political sustainability, and I would say one thing in our favor is that I don't think the status quo has political stability, and I think that that is further eroding every year. So even if there's still some cultural work to do, I believe that this work needs to be ready when the tipping point hits for the political stability of our current healthcare system. So I really appreciated that point being emphasized. My question is, and it doesn't need to be answered here, but I noticed that you emphasized the importance of incorporating health promotion and kind of public health generally as part of the healthcare system. And it made me wonder if our public health funding in Oregon, such as the public health modernization budget within OHA, the funding for the local public health authorities or LPHAs, is that included in our financing model as part of the system?
It's not. No.
It isn't, and I asked, information just yesterday. Only 115 million biennial is the total budget for the state and local public health. Now, that is less than decimal dust
Yeah.
in terms of what we're talking about here. And I think early on, before I joined the finance committee, there was discussion about whether to include those costs in or not, and it was decided not.
Yeah.
I think we need to discuss about putting it in light of what Dr. Chi and others are saying, that we'll never really get to the ultimate goal if we haven't included it. And since it's such a tiny little portion, it's not gonna make a big difference. I would argue that more needed to be allocated there.
And I can give an example of Taiwan's case, how population health promotion works seamlessly with the national health insurance. The national health insurance within its coverage already included lots of benefit that contribute to the population health, from screening, from vaccination and education, etc. But whenever, so that's how the national health insurance or universal health care contribute to the population health, not just in treatment, but in prevention, promotion. But whenever from time to time, the Ministry of Health identify national health priority. So for example, one of the current national health priority in Taiwan is control and possibly eradication of hepatitis B and C. And given that a priority, the national government appropriate an extra budget. And so that extra budget is funneled into the universal healthcare, the national health insurance. So any screening and even some type of treatment of hepatitis B and C come from that external budget, not part of the traditional national insurance budget. So it can work both ways.
Requires that agencies talk to each other.
Yes.
We don't have.
Okay, we need to move on. Let's shift to committee updates. Thank you so much, Sean Wade, for that presentation. We really appreciate it. And let's get started with the operations committee. I'll turn it over to Judy.
Thank you, Chair. So I would like to ask the board's grace and have you refer to your board packet for details, but present on the front side 2 recommendations that operations has been waiting to present to the board for 2 months, I think. And so this has been in the packets several times. And then perhaps you could go through some of the high level details so that the board has a general sense, but I'm hopeful that they've read the materials and can follow along. So the first one is about enrollment, and the basic recommendations for enrollment are the operations committee recommends that new member enrollment occurs immediately upon attestation of intent to reside in Oregon. Second, only the minimum necessary documentation is required for enrollment, including items that establish residency, determine eligibility for Medicaid or Medicare, and allow for member outreach. And then the third piece of the enrollment recommendation is that members would be automatically re-enrolled in the Universal Health Plan based on Oregon tax return filing and participation in other state programs. Affirmative member re-enrollment would be required only if all ex parte verification attempts are unsuccessful. So this is all about initial enrollment and re-enrollment. And when we get to the part that talks about when do benefits kick in, this is a conversation we're going to collaborate with the plan design and expenditure committee. So this first recommendation seeks approval of the board for these 3 elements of enrollment and re-enrollment. Questions?
So all of these dot points.
Chair, you have a question?
So new member enrollment occurs upon attestation. What form does that attestation take? Is that like tax returns or is it?
Go ahead, Leah, show that element.
Yeah, attestation would basically be a written statement that they could sign that says, yes, I live in Oregon or I intend to reside. And then as the committee put in here, a 90-day buffer where they'd have to show proof by then, otherwise that would lapse.
They have to show proof of what?
Proof of residency, so they'd have to submit a rental agreement or a lease or something.
So tax returns, proof of filing in Oregon wouldn't count. It would just
That would
be,
go towards re-enrollment processes. Presumably, they wouldn't have a tax return if they were new to the state. So this process, we're talking about new members. So we're not talking about people that have been domiciled, have lived here, have filed past tax.
oh,
returns.
okay. So initial enrollment of people moving to Oregon,
Correct.
not people who are already here. This is not enrolling. So the initial sort of bringing everybody on board would happen sort of automatically based on.
And for 90 to 95% of the population, they would be covered just by looking at tax returns.
That's what I
and
was referring to.
participating.
Yeah,
Yes.
Okay, yeah. So if you've been filing taxes here and you have proof that you've been living here, you're
Yeah.
automatically enrolled, and this is just for the small number of people moving.
Yep.
Okay.
And I think I heard you say that for people who weren't, who don't file tax because they're low income, that if they were on SNAP or on anything else.
Yes.
they're-
Other state programs.
Yeah, okay.
Can we add a statement to that? That high level summary, just to, that what you just said to me about, look, we anticipate the majority of people would be automatically enrolled based.
I think this is the slide that speaks to it, but I think this one, so re-enrollment, this would also be the kind of initial blanket enrollment to folks.
Oh, okay. primary mechanism, yeah, primary mechanisms, yeah.
Thank you for calling that out, because there's two stages, right? There's when the UHP starts. So that essentially the re-enrollment process would be the way that applies. But what the operations committee recommendation was doing was thinking forward into the future, all the years to come. People moving, how would you initially enroll and re-enroll in the UHP? Got it. Perfect.
Anything else on the enrollment? Is there a motion to approve the proposal for enrollment put forth by the operations committee?
So moved.
Is there a second?
Second.
Any discussion? Okay, let's do a roll call vote.
Ellen Belanca,
Yes?
Chen Wei Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Michael Leahy.
Yes.
Thank you, everyone.
Thank you, and thanks for your grace in allowing me to go through that. And similarly, I'd like to address the recommendation regarding subrogation and by all means, ask questions about it and we can find the relevant slide so we don't repeat everything that you have already read. So the operations committee recommends that a universal health plan does not replace, but works alongside third-party liability doctrines and workers' compensation in the following ways, and there are 4 bullet points. Plan members will receive medical care through the universal health plan regardless of liability involved. Providers will bill the universal health plan for all care. The public corporation shall have a statutory right of recovery, allowing it to pursue liability claims on behalf of injured members. And fourthly, the workers' compensation program will operate independently of a universal health plan. However, it will provide applicable medical reimbursements to the universal health plan. Questions, fire away.
I had been thinking, and I'm not part of the operations committee at all, but I had been thinking that we would actually bifurcate the workers' comp system and all the medical money that is currently being paid by employers and employees would come over under the universal health plan. The major reason I'm concerned about doing this is that the thing, like when you go into the emergency room, and the first question is, was this work related? And so there's administrative expense to that whole piece. And so I was thinking that you wouldn't have that anymore if you simply had safe and other workers' comp divided so that they continue to work on the paying for people that are unable to work or having, you know, that benefit. But the medical benefit, I'm wondering, was there discussion about why you would keep it over there versus going after the law that says we're going to change it and put it all over teams?
Thank you for that question. Yes, we've been really lucky to have great presentations by state, both when we were thinking about setting up the trust, but also thinking about it as its own program and a highly functioning program as it is. And Lee, do you have the slide about maybe workman's comp?
About the organ program?
Yeah,
Pull it up real fast.
thank you. While you're pulling that up, appreciation and gratitude to staff for assisting with all of these slides and background work. We might need to talk a little bit too about
Yeah,
the
maybe
background of
if you could stop.
subrogation.
Oh, I'm sorry. Did you want to speak to this? Or would you like-
Go ahead.
Just briefly, so yes, we did examine the current state of the workers. Oregon workers' compensation program, excuse me, and we're actually extremely lucky. We live in a state with one of the top rated workers' compensation programs. And that was part of the logic for not wanting to get involved in that program. They have a really strong system. These are four really common metrics: employer costs, benefit adequacy, administration delivery, system sustainability, and reputation. Oregon performs in the top order, I would say, on all of them, but in particular, extremely well on cost. It is considered a national model in terms of system sustainability and reputation, producing reports that other states use as a model. So that was, I think, the primary logic of the committee.
So the idea is don't try to intervene because it's not broken, like it's working really well, let it be how it
It's
is.
rolling really smoothly.
It's going really smoothly. And so despite the fact that there are added administrative costs at the clinical site, it's worth it because they operate the system so well. Is that the idea?
And I don't think there would be added administrative costs at the clinical site because, as a clinician, you would continue to bill UHP. It would be at the UHP central administrative site that goes for, the subrogation gets the reimbursement from the liability insurance.
You would still need to find out when people come in. There's that piece, I mean, you can go to the emergency room immediately, somebody is there going, you know, is this work related? Is this automobile related?
But we
Is
would
this-
need to file the claims with them, so that piece would be
So
fine, and
that
that's
would
probably the more.
receive
yeah.
Right, so it'd just be like identifying it and then flagging, it'd be like flagging it in the claims, right? And
Yeah, it's
instead
like a
of
flag
having to-
eligibility.
Instead of having to bill a separate system, so there is some reduction in the administrative burden.
I guess I'm still not
Which
convinced to do it, but,
the provider.
you know, but anyway, I don't know whether there's. You know, anyway. I guess this kind of is like, okay. Really different than I was thinking, and I'm gotta shuffle my brain and think about it, and so, as again, these are preliminary recommendations. And, we can still then think about this in the transition committee or is even a second step or something like that. But just was not how I was thinking.
Was there any discussion about breaking it, splitting it? Or is it just that it functions so well, we better not mess with it?
That was where the committee landed. We didn't have a long discussion about breaking it out.
I have had a brief conversation with Bruce Goldberg, who's on leave here, but he's also joining that board. And he was thinking more about actually separating workers' comp into the two parts. So he's not, he's a member on the board, I don't pay attention to the whole sacred workers. So, I'm speaking a little bit without knowledge or whatever, but just my thought.
Any other questions or discussion about the subrogation? Go ahead, Michelle.
Thank you, Chair, and thank you, Judy and Operations Committee for this proposal. I was actually really excited to see it come through. As you would imagine, reading a proposal on subrogation, the immediate response is excitement. Because in my recent community engagement with the Southern Oregon chapter of HCIO, this is actually one of the things that they asked about and strongly recommended that we consider based on some of the data from other countries. And so I really appreciate this thoughtful proposal and I'm ready to support it in this preliminary form pending more engagement. But thanks for this work.
Go ahead, Jenny.
Is auto insurance included in the consideration or not yet?
Yeah, any liability agency would be with the UHP would enact subrogation to go for and get the funding from that liability company.
So again, with auto insurance, people would still need to indicate that this was an auto accident when they seek care and it's flagged. And then UHP is billed and then UHP seeks reimbursement from those other rates. Right. Yeah. Any other questions or comments? Is there a motion to approve the subrogation policy as presented by the Operations Committee? Sorry, it's not a policy, it's a preliminary proposal.
So moved.
Just one amendment may need more work, but that's not related to the vote. That is for auto insurance. different insurance company may have different policy about the rate of reimbursement. And that's the detail we need to work out.
So it's been moved to approve the policy. It's been suggested that there be some added, if there isn't already some added language in there about equalizing rates among providers. Is there a second?
Second.
Actually, we should probably just back up and make a new motion. So, is there a motion to approve the policy with the edit recommended by Chun Wei to add some language about normalizing rates among the providers? Looking for a new motion for that. Okay, Chun Wei moves that. Is there a second? Okay, 8 seconds. Is there any discussion? Okay, let's do a roll call vote.
Ellen Blanca,
Yes.
Chun Wei Chi.
Yes.
Amy Fellows.
Yes.
Michelle Glass.
Yes.
Bruce Goldberg is on leave. Judy Richardson. Yes. Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Michael Leahy.
Sort of, yes. I just want to go on record that if we get additional information from this, we always have the ability to potentially fine tune this one, but I vote yes.
Thank you.
Okay, great. So next, I'll leave it with Judy. We're gonna be talking
Michelle
about.
have her hand. Sorry.
Sorry, go ahead, Michelle.
Sorry, just point of order. Do I need to rescind my former motion or
Yes.
process? Okay,
Yes.
I rescind my motion, just so it's clean.
Thank you, yes.
So just to wrap that up, thank you to the board for your suggestions and your recommendations. The committee just makes recommendations to the board, and it's up to the board to determine the path forward. And we're happy to tackle any additional work around that recommendation if necessary, but would defer to expertise.
Great. Okay, so next we will be creating a new committee today at the board meeting. This is a committee we've talked about from day one. It was originally intended to be part of operations, but was moved out to its own separate committee. So this is the transition committee. And we'll be going over the charter in a moment, but the basic goal of this committee is to transition our just to kind of put together some initial thoughts for the legislature on how they might transition our current healthcare system to the one envisioned by the Universal Health Plan and sort of the steps needed to make that transition. And so we have already had 2 volunteers from the board to be members of this committee, Judy Richardson and Mike Leahy, and they've also agreed to co-chair it. And so I'm looking for a motion right now to establish transition.
Volunteer, board member volunteer as well.
I don't know. I'm sorry.
If you look on the slide, there's another board member.
Okay, and Mary Lou, right, so right, okay, so first I'm looking for a motion, first of all, to establish the transition committee and appoint our volunteer board members, Judy Richardson, Mike Leahy, and Mary Lou Henrich has volunteered as well.
Second.
So did somebody make the motion?
Yeah.
Okay, so Cheryl's making the motion.
Second.
Judy in second. Is there any discussion? Okay, let's do a roll call vote.
Ellen Blanca,
Yes?
Chun Wei Chi.
Yes.
Amy Fellows.
Yes.
Michelle Glass.
Yes.
Goldberg is on leave. Judy Richardson. Yes. Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
That's everyone. Thank you.
Great, thank you to the 3 of you for volunteering for that. And then there has been some work to develop a charter. We need to approve the charter for this committee. I'll turn it over to Judy to go over that.
So do you have a slide? Oh, thank
That's it. That's
you.
just, that's a
Great.
summary slide, and there's actually in all the board members. Well,
You'll
it's
have
in
in
the
your packet
packet.
the
Yeah.
whole charter. Thank you. The primary purpose of this committee is to develop and recommend the board's consolidated transition roadmap that synthesizes outstanding issues, dependencies, and sequencing considerations for board deliberation and decision-making.
Great, is there a motion to approve this charter?
I make the motion to approve the charter.
I'll second.
Any discussion? Okay, let's do a roll call vote.
Ellen Blanca,
Yes?
Chun Wei Chi.
Yes.
Amy Fellows. Yes. Michelle Glass.
Yes.
Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thank you.
Excellent. And then, per our process with other committees, Judy and Mike have both volunteered to co-chair this committee, and as such, they have thought through, about membership of this committee, and I'll turn it over to Judy to talk about.
Thank you, Chair. As you all know, there's some, I think, art and science into balancing a committee with expertise, interest, and trying not to make it so large that work can't be done and so small that you can't move work forward as well. So we solicited recommendations from each of the committee chairs, specifically asking for folks who have either experience or knowledge of implementation, science, startups, transition, or have particularly deep knowledge and work of the committee that they served on, because those work streams, while their deliverables are wrapping up, their expertise and historical knowledge will be useful during the transition. So Chair, I respectfully submit this slate of volunteers, voluntold for the board's recommendation.
Great. Is there a motion to approve? So Judy and Mike are already on the committee, as well as Mary Lou. So is there a motion to approve Charlie Swanson, Richard Gibson, Jamie Osborne, Paula Weldon, Antonio German, Anne Lovejoy, Eve Gray, Nikki Durding, and Jensina Hawkins as committee members of the transition committee?
I so moved.
A second.
Any discussion?
I would just like to add that there's been some incredible work done by the various committees and others. And I think we should just say that as we have issues, whether it be pharmacy or health information technology or further simplifying administrative costs, right? That we will clearly be open and to any and all ideas. And I especially want all the board members to feel free that if they have a particular item to fully participate. I think that maybe that goes without saying, but sometimes it's good to clarify things.
So any board member is welcome to join this committee and participate fully as a committee member. But like other committees, the board members are welcome to listen in as audience members, but can't participate in the discussion unless they're a member of the committee. But yes, I agree with you that the more we listen into the work, we'll all have a better understanding of how it's going. So if there are any other board members who are interested in joining this committee, you can make yourselves known now. Otherwise, we would listen in as public members.
I'm wondering if there's something that's slightly different in this one, and because it's so important, whether board members could be considered ex officio or something like that. I don't know, is there something in between?
I think
No?
the problem with that is that we then have to establish what is quorum. We both,
Oh.
I mean, we still have to function as a public committee of the board, yeah.
And like all of our committees, the recommendations of the transition committee will come before the full board for our discussion, as they always do for the other committees. So everyone will have a chance to weigh in eventually on all proposals. Yeah. Go ahead, John.
So this is just a suggestions that the committee might already consider that is whenever the transition committee come to a certain point of decision or recommendation, we can bring that to the board for further discussion. Not until the end, the full report, but we can discuss as we progress.
That was the original idea. Way back when we started the committees, that the preliminary straw proposals will be brought to the board, we discuss it and kind of get more feedback from the board, and go back to the committee and then come to the board a second time for final approval. That's how committees were originally designed to function. There were so many things that got in the way of that process, so we ended up not being able to make that happen, mostly due to time constraints and staff turnover and a lot of other issues. But yes, I think trying to implement it for this committee is a very good idea, to bring a preliminary straw proposal, to work it through with the board, and then bring it back to the committee for final details. Yeah, thank you for that.
I think that the spirit of what we're talking about, Chandra, I think is that we've got to get beyond this kind of functional look of committees to this isn't gonna be much more of an iterative process than it is gonna be the sequential design up till now, and I wanna make that clear, that as the transition committee should have the ability to say, we wrestle with this and this is what we think, but we don't have a clue on this other thing and we need some help.
Yeah, on a related note, that from time to time, the committee, the board might have think of important subject, important issue that require further work, further detailed work, and we can recommend the committee to consider those subjects.
Yeah, great, thank you. Okay, it's been moved and seconded to approve these committee members. Is there any further discussion? Okay, let's do a roll call vote.
Helen Belanca,
Yes?
Shenwei Chi,
Yes?
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thank you.
Okay, great, and thank you to the three of you for taking charge of that. Great. Okay, so I'm gonna pass it to Amy and Michelle for the community engagement communications report out.
Michelle's gonna lead.
Thank you, Chair. Good afternoon, everyone. So as we've been giving these updates monthly, there isn't a lot of new material to report. I'm happy to report that we are on schedule for what we've been talking about the last couple of months. And so just a quick refresher, in November, we brought Diana Bianco from Artemis Consulting back from her contract being on pause. And she, staff graciously spent a lot of time getting her up to speed on where all of the work stood with each committee and with the formulation of the plan design. And I want to thank all of you board members, many people in the audience, and the CECC committee for all of the suggestions that have gone into this these focused engagements that are going to take place in March. So a lot of work is happening behind the scenes. Thank you to the chairs of the committees for your help as well over the last couple of months. There's been many meetings. And so all of those inputs that CECC and board members have been sending us for months are being implemented as we speak. So Wentz Jackson has been developing amazing materials based on the work of operations, plan design, finance, and revenue to lay out for focus group participants. Here's the preliminary proposal. Here are some of the concepts that the board has done their due diligence on and wants your feedback on. Here are some of the trade-offs, and then designing some questions. The board's been designing some questions around that, including a lot of input from the committees and the committee chairs. So really want to thank everyone for all of that work and let you all know that those engagements, invitations will start going out next week. And that participants have been selected based on all of those suggestions and inputs, then also reviewing the bill and the statute to make sure that we are meeting what the legislature expects. We also identified a clear set of criteria to make the process as fair and equitable as possible. So participants were selected to reflect statewide diversity, meet legislative requirements, and ensure balanced input across sectors. And we recognize that because this is a limited focused engagement, not all interested organizations and individuals will be able to participate in every opportunity. And so, this is just one of many, we've just reached the point where we can start focused engagement and get people's responses to a proposal. And that has been the biggest hurdle. So I want to thank the committees for all of the work that got us here so we can really dig in and get not just generic feedback of like, what do you think of the vague idea of universal health care, but what do you think of this way of financing? What do you think of this benefit structure? What works, what doesn't? That's where we've needed to get. And that's where we're at today, so which is really exciting. So this is the first, it's limited. There will be many other components to community engagement. So we just want to be clear that if someone doesn't get to participate in this particular opportunity, it does not mean they will not be engaged. Also want to make it clear that a neutral consultant will facilitate the discussions and that the consultant is not selecting participants. That is the work of the board. And that's the board has come up with the criteria and is basically giving the consultant a list that the consultant will then facilitate with the participants the board has selected. Board members will not attend. And that is to allow, to create a space where hopefully everyone who comes to those focus groups feels really comfortable speaking, whatever their perspective is. And so the report will come to the board de-identified, so it won't be like Cheryl said this in the focus group, right? It'll just be the themes. It'll be, sorry to pick on you, Cheryl, the themes and the concerns and the questions and in aggregate from all of the focus groups. So we really want to hear people's input and we want to create a space where people feels comfortable sharing whatever those things are as possible. There'll be virtual sessions and they will include 12 to 15 participants. And that is a number that we believe will allow everyone to participate. And attendees will receive a summary of the preliminary recommendations and then provide their feedback through structured facilitated discussion. And again, all individual comments will remain confidential. So we're excited to bring back the results from these engagements and again, really appreciative of all of the hard work that's gone into making this process possible and excited and grateful to our consultants as we move forward. So that next slide, please. I think that's the big update. In terms of the committee itself, you've already heard that the committee met in January and voted to change our time. So to create an opportunity for an hour of public engagement after 5 p.m., which is really exciting. Because of spring break, as Amy mentioned in March, that meeting will be on the 11th from 4 p.m. to 6:30 p.m. But moving forward, it will revert back to our normal fourth Wednesday of the month from 4 to 6:30 p.m. The other update, which we mentioned last month, but staff and Wentz Jackson Consulting have helped put together a beautiful slide for you all. So I hope that everyone online and in the room and board members have been able to check out the improvements to the website. Again, we're a little bit constrained because we are hosted within a state agency website, but we're really grateful to the DCBS communications team for all of their support and to Wentz Jackson Consulting for making our website as user-friendly and up-to-date and plain language and information-rich as possible. So let us know if you have any additional feedback, but these updates have all happened. So we have the updated mission statement, principles, the one-pagers can be downloaded, and there's also some more resources on the resources page that's linked there. I believe that is everything, unless there are questions.
Any questions? Great, thank you so much for that. And I'll pass it to Cheryl for finance and revenue.
Okay, I'm going to give just a very brief high-level overview of what we covered in February at our meetings. Then I will mention what we're going to talk about in March at our 2 meetings in March. And then I'm going to just cover very briefly a couple of votes that we anticipate in March. And I will make a motion on a recommendation that was made by the committee to the board. So that's what I'm going to do. So in February, there were lots of questions for Milliman on the cost estimates, and you saw a lot of the slides already. Those were the ones that the Finance and Revenue Committee were asking about. I think we got some answers, and I don't know if we fully answered all of the committee questions, but I realize there will be a lot of work on reconciliation between the cost estimates and revenue, both in the transition committee and in the board. So understand that's future work. We talked about the plan for reserves and a strategy around the reserves. And then recalibrated the revenue target a bit, tweaked that. So in March, we plan to vote on the basic tenets of the revenue plan so that we can bring that forward to the board in time for the March board meeting. We are going to review the revised reserve strategy after we made comments at the last meeting. That will be tweaked a bit by Echo Northwest. And then at the March 17th meeting, we plan to review the draft Echo Northwest report on all the work that's been done in the Finance and Revenue Committee. And I imagine there will be a vote on that probably. Okay. Other votes that are coming up, most likely, I would guess even as early as March 3rd on this one would be to vote on, and I'm using a technical word here, scrapping the household size rate adjustment. It's really super confusing. And we think we can get at that a different way. Also, the juice may not be worth the squeeze, so to speak. We also may be voting on, or at least discussing, Medicare Part B refunds. We have it as a non-refundable now, so we're going to be talking about that, and there may be a vote in the committee on that. And then last, I am going to make a motion from a committee recommendation to extend the Finance and Revenue Committee through September. So with that, I'm making that motion.
Is there a second for that motion?
I'll second.
Any discussion? Go ahead, Michelle.
Thank you, Chair, and thank you, Cheryl, for that, for bringing that forward from your committee. This is so hard, and I do feel strongly that while the work of the committee is so critical in getting us to this point where we can start real community engagement and put something in front of people to get some specific feedback on. I know that with our limited timeline and staffing and funding, that our work, our CECC work, needed to be put on hold. And that was hard for CECC. We got, our committee didn't like that. It was hard for those of us who were excited to do engagement, but we knew that in order to do good engagement and make this plan as strong as possible, we needed to have the components that Finance and Revenue was working on and the other committees were working on first. And us going on hold with our engagement contract gave the staff capacity to your committees to do that heavy lifting. And that was critical. Now we need that staff capacity to complete our work plan. Amy and I, as volunteer board members, cannot provide enough capacity to fully support the consultant work for these, all of these meetings and all of the behind the scenes work that needs to happen to make this engagement possible on a timeline that we can bring that feedback back to the board to change, to impact the recommendations that go to the legislature. So I just want to say with a lot of humility and appreciation that, I wish we could do it all, right? And we can't. And so I do want to just make the case that this work is so critical. This is so critical, as we've all heard from Dr. Chi, as I think we all believe. And without the staff capacity to support it, it's not going to be successful. And we're not going to be able to complete it within the timeline that we've laid out, which is really ambitious. And so I would just say, in my mind, it is a trade-off. I don't know how we do both. And we know the impact of losing our staff team. I do not want to risk burnout. I do not want to risk losing the fabulous staff that we have, and setting the work back again. So again, with humility, with respect, with appreciation to the committee and its work and its critical role, that would be I will be a no on this, and I wanted to share why.
Thanks, Michelle. And I just want to say before we call on everybody else, for those reasons that you laid out very well and the ones that Helen also discussed earlier, I did not vote to support that recommendation in the committee. So with that, Mary Lou, go ahead.
And I, as another member of that committee, did vote to at that time. But going back to my Maya Angelou quotes last time about you do as best you can the moment with what you know, but when you know better, you do better. And I think that in the discussion that has evolved in this last 3 or 4 weeks, however long it's been, I will vote no today, although I voted yes at the committee. And I just wanted to explain why. And I think that the fact that the Transitions Committee and having 2 of their very strongest members of the Finance Committee who really did a lot of that delving and background and then explaining, both Richard and Charlie Swanson, I think going to the Transition Committee, and that I'm just feeling like, and with plan design, one of the things that I know we've all been frustrated with was not really in the beginning putting something together between the 2 of those committees, and so having a little bit disjointed things going back and forth, that the people who are going to be on that Transition Committee from plan design, I think are also very strong members. And I think that the work that needs to be done to continue this, will be done through that transition committee. So I just wanted to explain why I was, voting yes, and now today I would vote no.
Thanks, Marilyn.
I had a question, I guess, to Michelle and Amy, and that is, Judy and I had a wonderful conversation with your consultants. But I'm still not clear on when you're engaging with folks next month, how clear can you be?
Mike, sorry, we're talking about the Finance and Revenue Committee now and whether or not to continue it into September. If you have questions for Cheryl for Michelle and Amy about their work with Artemis, we can address that at another time.
I think once you allow me to finish,
Okay, go ahead.
I think you'll see there is a connection here. So my question is, do you have enough when you do this engagement stuff to begin to have an intelligent conversation regarding the financial implications of this plan? Like whether are we asking people to pay 10% tax or 5% tax, whatever? And if you do, I mean, that's great, but it's a difficult question, but
The
it's.
board that sent the draft questions, I think
Yeah.
they're supposed to give feedback yesterday, so I think you'll saw what they were. We can determine from looking at. the
Well, I
draft
just want, the two of you, if you feel comfortable that you can do all these sessions, but maybe we haven't as fully developed the plan as we should. And that's why I think it's relevant about whether or not we need some other special sessions.
I think there's been enough work done to at least point to a direction, even without final exact numbers on everything. But that's the whole idea, is that we want to get feedback from these groups and then incorporate them into our final recommendations as a board. So it doesn't have to be final numbers, so. But yeah, the feeling was,
Rationale.
it was far enough along in the work that it was reasonable. Go ahead, Johnson.
Yes, as we are moving towards kind of final stage before our final product, I think it's time that several committee have to work together rather than separate committee, particularly on finance and on expenditure and benefit. Plus the vital information I mentioned, that we need to have good idea what is acceptable tax rate. And that will be a very important condition to combine the finance and expenditure benefit together with that information. And so with that regard, I think given the time constraint, it's time that all those subjects need to work together rather than separately.
Yes, I agree, and I'll respond to that by saying that that's the work that happens at the board. It is not the job of the Finance and Revenue Committee to reconcile the revenue with the expenditures. That's not their role. Their role is to get as close to our projected expenditures as they can, and then present their best proposal, and then it's up to this board to decide, do we want to change their revenue recommendations to increase the revenue to meet expenditures? Do we want to reduce the expenditures and benefits in order to meet the revenue? That's a board discussion. The committees will not be meeting with each other. We've run out of time and staff capacity to make that happen. I know that was proposed long ago. We just ran out of time and capacity.
And any additional needed work will be done through the transition committee.
Yes.
Right, so there's been a motion and a second to continue the Finance and Revenue Committee through September. Is there any further discussion? Okay, let's do a roll call vote.
Helen Belanca,
No?
Chun Wei Chi,
No,
Amy Fellows,
No,
Michelle Glass,
No,
Bruce Goldberg is on leave. Judy Richardson,
no,
Cheryl Ramirez,
No.
Mary Lou Henrich,
no.
Mike Leahy.
No,
thank you, everyone.
reluctant, no.
Okay, I want to just wrap that up by saying we deeply appreciate, again, the expertise that has been provided to this board from the Finance Committee. And the fact that we still hope that we can tap into that expertise as our work continues, either through your work on the transition committee or through individual outreach and engagement with this board with public testimony. And we really hope that you will remain engaged even if that committee does end. will end now, I guess. Thank you. Okay, moving on to plan design and expenditures. I'm gonna turn it over to, Lee to give a little update on our work, but, the, plan design committee has been doing really great work, wrapping up our behavioral health funding proposal and then delving into a deep talk on cost containment. And as I mentioned earlier, we anticipate a final discussion and recommendation on long-term services and supports. But for the purposes today, we really would like to put forth this proposal on behavioral health funding and get that one tidied up. So I'll turn it over to Lee.
I'm gonna zip through this real fast. So we are talking today about behavioral health integration, funding, et cetera. We're not talking about benefits. That's something this board considered last March. So here are our 3 topics. Slide, please. So jumping right in, funding alignment, pretty basic, settled on kind of a high level principle that if it is medical, it should be aligned with the universal health plan. And if it is related to public safety, so things such as commitment or crisis, that should remain as a separate bucket. Next slide, please. Regarding behavioral health payment, we discussed having a model that included 2 components to it. One, in which they would be paid for those clinical services, but ensuring, of course, that our behavioral health, it really needs to catch up to some of our other payments. So also including an infrastructure component, which would allow for expanded capacity for those folks to have, for instance, walk-in care coordination and perhaps expanded hours as well. Slide. And finally, we discussed a model for integrating behavioral health more closely with primary care. This kind of funnels into what we've already discussed in terms of regions being more accountable at the local level. I'll reiterate it just one more time. Regions are not networks, but they are going to be responsible for knowing the providers in their area and helping them to foster connections with each other. So under this model, the regions would essentially get to choose their level of autonomy and support that they receive from the public corporation, depending upon the structure of, what their region looks like, if it's really rural, if it doesn't have a lot of providers, if it's relying more on telehealth, et cetera. And they could choose one or a hybrid of these options as is appropriate. So a lot of flexibility for them, but really ensuring that regardless of where you are statewide, you're going to be subject to those same standards and receive whatever level of support is appropriate. Next slide. That's that.
Great. Go ahead, Amy.
Yeah, I had submitted some public testimony to this group when the topic was being talked about, and I guess I'm still a little bit unclear that anybody can go to any mental health provider. Absolutely. So we're encouraging the integrated model, but not strictly, of course, requiring, because I know in our current environment, CCOs have stopped working with independent therapists that are more likely to be
Right.
people
No, that's
of
not,
color, disabled, and I've watched families fall apart over that decision.
of course, yes.
So
I want to clarify that there's 2 integrations that we're talking about, and they might be getting conflated here. Okay, one integration is the funding. And then one integration sort of is the delivery of services, like how people get care, where care is delivered, how the clinics and clinicians talk, and work with each other. When we're talking about integration here, we're talking about the funding integration, pulling in any of the behavioral health funding that pays for direct behavioral health services should be integrated into the universal health plan funding. And we're keeping separate funding that comes from other sources that pays for safety and correctional institutions. There's a separate pot of funding in behavioral health that's for public safety, and we're keeping that separate. So when we're talking about integration here, it's about
I
that.
just don't want to have an unintended consequence of further limiting
Right.
our mental health workforce
Right, of course.
to not be as diverse.
We don't want that either.
Okay.
And so there is no proposal that all behavioral health is integrated into primary care. That's not the proposal. Of course, the primary care, patient-centered primary care home still exists, the CCBHC still exists. But the independent providers out in the community are also still part of it. Any licensed provider is eligible for payment under the universal health plan. That's been the case from the beginning. Yeah. Great. Any other, oh, sorry, Mary.
Okay, can we go back to the first slide, please? Okay, Wait, no, I guess, I'm sorry.
Yeah.
Okay, so behavioral health funding for services with no public safety component should be aligned pending relevant federal approvals. Okay, so when you have, I just know from my experience in my past, and Cheryl knows much more than I do about the complexity of what counties do in terms of crisis and other things that, and sometimes it's with the forensic stuff and sometimes it isn't. And I guess I just was kind of like, looking at. Is that second blue, thing that says Medicaid, OHA behavioral health, federal SAMHSA? I'm just confused. And if Cheryl says it's okay, I will be okay with it because I just know, okay, because I just know. A lot of people have worked very hard over the years with very minimal funding, and there's been this tension between the counties, when I worked for the county, feeling that we got the really tough mental health cases, and then when money went over to CCOs or however else, and I've lost track of how it's all funded, but it was kind of like, well, they got the lighter part of it, and I just want to be sure that Cheryl's okay.
Oh.
Because this is your real work.
Yeah.
And so I'm going with what you said.
Oh, well, thank you, Mary Lou, and I want to say amen to what you just said. So what I would say first I want to thank you for addressing concerns we've had about this very issue that you're mentioning, Mary Lou, that there are some parts of the public behavioral health system that don't quite fit into this universal health plan. Of course, the highest level of care, institutional care at the state hospital, those services provided for people with legal system involvement, the first responder services, the responding to a behavioral health crisis. So we appreciate that. I do have just some questions on finer details, which I hope we get to at some point in this process, and that is how we reimburse the acute and highest levels of care in the community. So crisis stabilization, respite, withdrawal management, and various levels of residential treatment, because that will be important to the public behavioral health system too. So I do want to continue talking about that and address those issues. And third, I wanted to say that we truly believe in integrated care in the public behavioral health system. And just want to note that even though the focus here is a lot on primary care homes, there's probably 5 to 10% of our population who are going to identify a behavioral health agency as their primary care home. They feel more comfortable. Their primary diagnoses are serious mental illness, chronic substance use disorders, and they will go to their behavioral health agency for their primary care. So I just want us not to ignore that, and the fact that this small percentage of the population, which also is very costly, needs team-based care. They need in-person care. We can't solve our behavioral health problems and workforce problems with telehealth. It's not possible. And so we need to make sure that we reimburse these providers in a way that they can make it work. These are fidelity-based programs. It's team-based care. It's costly. Fee-for-service will not fund this type of work.
So, yes, thank you. We had a lot of rich discussions at the committee about this issue, and what I will say is part of the background of why the system exists as it does is because we've always separated behavioral health from physical health. And we passed along the state many years ago, long time ago, that there should be mental health parity, right? And so, but that has never been realized, partly because the funding for behavioral health has been so separate from the funding for physical health, for lack of a better word, right? And so the idea of integrating the funding is to create that parity and to change the way it's paid for and reimbursed, to really to pay for it as a medical condition as it should be, and not hold it separate from the medical care. So that's the integration mostly that we talked about. I want to invite Judy if you want to say anything too about the architecture and kind of, so I want to extend, first of all, huge gratitude. The committee benefited from Cheryl's knowledge to help with understanding the funding situation. We definitely tapped into her when we were building this. And then the architecture of how care would be delivered is fully based on a model that Judy developed. And so we're deeply appreciative of Judy's offering her regional access model to us. And if you want to say anything more about that.
Thank you. Only that, we really tried to base this on the operational structure that we came up with in operations committee, and then taking in feedback for living in a rural state, living in a state where there's scarcity of resources, and thinking about the entire population and how do we access care. It's not perfect. It's a first step.
Any other questions or discussion? Haven't yet had a motion. So is there I don't think that this was for the committee.
Yeah.
Yeah, so we don't need to do the breakdown here, but is there a motion to approve the behavioral health proposal as presented by the Plan Design Expenditures Committee? Is there a second?
I will second.
Is there any further discussion? Let's do a roll call vote.
Ellen Belanca,
Yes?
Shenhui Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson. Yes. Cheryl Ramirez.
Yes.
Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
Thank you, everyone.
Thank you. Okay, we are at 12:27, and I want to ask the board if all of us are willing to extend our meeting by 10 minutes. We still have to cover the federal and state health policy update, which will be quick, but then to allow us a few minutes for public comment. We have 11 people signed up for public comment. And we probably will need about 15 minutes total, still going until 12:45 to cover that. Could we get a roll call vote if people are able and willing, and please, if you're not able or willing, let us know, but if you're able and willing to stay an extra 15 minutes to finish up our business today. Let's do a roll call.
Ellen Belanca,
Yes.
Shenhui Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Goldberg is on leave, Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Okay, thank you all. I appreciate that. Okay, so I'm going to turn it over to Lee for a federal and state policy update.
All right, not too much here, just wanted to make everyone aware of, these are some of the state laws that became effective at the start of this year. So a couple interesting things, medical debt being removed from credit reporting, a couple different, changes to coverage options for, OHP. Here in DCBS, we've got our team working on stronger network adequacy and access standards, rate review transparency, and some ambulance surprise billing protection. So if anyone has questions, wants to know more, feel free to shoot me an email. I'll get that to you on that.
Just a quick question. I noticed there was some proposal or work session in the legislature about emergency services and
It died. It died.
so it died. I just wondered where the hell did that come from? Okay. It wasn't meant to be a comment, but I guess it's going to be received that way.
I'll also add in here that just as of this morning, there was a bill proposed to the House Rules Committee about from Governor Kitzhaber and his healthcare sustainability group about an effort to create sort of what he's calling a North Star for the work of the state in the next few years to align all of our efforts toward a more efficient, effective, less expensive system. The bill is very much in alignment with this board's work. It doesn't mention the board specifically, but we're very much in alignment with it if you're interested in seeing a copy of that.
And what was the number again?
It's 202, HCR 202, presented today. Okay, so for board outreach, I think as just a quick reminder that everybody, if you get requests for board outreach, that all those requests should go to Mimi. And then any future topics, this is the chance to weigh in at this point about topics that you would like us to cover on our coming agenda. We've already spent some of the meeting today talking about what those topics are going to be coming up, but if we're missing anything or you think we need to spend more time on a topic, please let us know now. This is your chance to in part of the agenda planning. Done right?
One area probably need the staff's help is give us some update in the future meeting about what is the progress being made in Washington State.
Oh, yeah.
Happy to do that.
Oh, that's good. And I wonder about California too.
Talk about them too.
I had brought this up before and.
So Amy, she was,
I'm sorry. I'm sorry. No,
Just, I mean, I noted this before, but, just when it's appropriate for the long-term services.
Yes.
Let's conversation from that.
yeah, so there'll be a proposal in March from Plan Design Expenditures. And then, and that's, yeah, it's next month. And then after that, we can kind of dive into that as a board, after we hear the proposal from the committee.
I'll reach out to you.
Okay. Yeah, Michelle. Oh, and then Mary Lou.
I just was going over old minutes and one of the things that was a question for the board that I don't know that we have really solidified or said, I know you talked to the finance committee about, are we developing a single payer health system? And this was the August 21st minutes saying that they'd like, we'd like the board to speak on that. And so, and I know that you gave something to the Finance and Revenue Committee, and I'm wondering if we could just put that on the board agenda.
Tried to do that today as my presentation. Yeah, that's a universal, it's universal coverage with unified financing plan within the legal limits of a single payer. Yeah.
Okay.
Yeah, but we can
I guess what
revisit it.
Yeah, we
can
can
revisit
vote on it as a board.
Okay.
That's all. We vote on lots of things. It just feels like this kind of essential to be sure. Designing the same house.
Okay. Go ahead. Ken. Oh, wait, Michelle, sorry. Go ahead, Michelle.
Two threads, thank you, Chair, that I wanted to just make sure don't get lost from this conversation. Today related to financing is I would love to dig more into delinking financing from over-reliance on employment. So that general income conversation that Dr. Chi was referencing. And then also further integrating public health and LPHAs and public health modernization and prevention into the system, I think is worth, in my mind, worth further discussion by the board. Thanks.
So adding on to that, removing financing, decoupling it from the employment, we've gotten several pieces of testimony, and then Sunway in his presentation also mentioned, I'm gonna forget the name of it, but taxing investment income, capital gains and investment income, and looking into that, and what are the possibilities there. Yes, great, thank you. Sunway's next, sorry, yeah, go ahead.
Two more subject, one is more urgent probably for the March, is given the time constraint we have, probably the board, it will be helpful for the board to talk about what will be the priority subject we need to prioritize, because we cannot cover everything. So for example, what will be the big structure that we need to settle before September? And similarly, related to that, the big structure probably overall, what are the important topic we need to decide by next month, that we prioritize the remaining months. And then the second related topic is to discuss this will continue. What are other potential saving under universal health plan that the current estimation did not include or did not have an accurate estimation? So besides administrative cost saving, the precision drug, we are monopoly that we have a huge leverage to cut down the precision drug costs. And similarly, with the other contracting, we will be a single payer to pay most of the medical bill. So we have that leverage to cut down the payment to equal, not just equalize it, but also cut down, because there's a cross subsidization in the current market. So these are just example. We need to explore what are the other potential savings that we can help us bring down the estimated cost, therefore reduce the tax burden.
Yes, thank you. Yeah, that's great. Summary of what needs to happen there. Great. Okay, anything else? Excellent, thank you. Okay, so we have 10 minutes for public comment, or less than that. We have 8 minutes for public comment, and we have 11 people signed up. So I will ask our public commenters to please try to limit your comments to 1 minute or less. And we'll get started with Lou Sinninger. We'll start with the online ones. Are you okay with that as well? Yeah, okay, let's start with Lou Sinninger.
Stop sharing.
Do we have a time clock or?
Because I can't screen share, I can't show it, but I
I'll
will
put it
put
in.
in the chat when we're at, to give a 30-second
Yeah.
warning.
Or you can verbalize it too.
Am I on?
Yes,
Being reduced to a 1 minute is a bigger insult. Again. However, when you go before the legislators, remember to lay out a plan and cost for an end product for the 2020, for the 27-29. Also, I wanted to mention workers' comp. You've just denied, say, 50% and everybody paying taxes, 50% of the savings. Lastly, I want to say, I'm sorry I'm so abrupt, but I don't have time. The expenditure and review, I pity engagement to have to put Milliman's up on the screen when they talk to people. This is a disservice to ignore the savings that a single payer plan would have. All you did was now you're talking about cuts and cost sharing without ever going into how much administrative savings it would have. Just think, no more pharmaceutical ads on TV, no more, oh, talk to your doctor about this. So, no more profits. Thank you very much.
thank you, Lou, and I encourage you and everyone else to submit written comments if you have more details that you want to share.
I will do that.
Is great. And then next is Jacquelina Naganuma.
Should I go
Sure.
now?
Dear Universal Health Plan Governance Board, this is on behalf of over 200 HCAO members. Thank you for the time and effort you are devoting to the development and funding of universal healthcare for Oregonians. We fundamentally believe equity should remain a guiding principle for this plan. We sincerely appreciate the thoughtful changes you have made towards this goal, such as including a corporate tax, removing the soft cap on the healthcare personal income tax, and adding a credit for Medicare Part B premiums. However, we believe that the current proposal does not meaningfully respond to Oregon's extreme income concentration or to the real cost of living pressures faced by working and middle class households. Numerous public comments have urged you to prioritize a truly progressive tax, and respected local economists such as Mary King have publicly affirmed the importance of a wealth tax so that those who can pay without hardship contribute more. The United States stands out among wealthy nations for extreme inequality and limited chances for people to improve their economic status over generations. As we have testified before, the top 10% of Oregonians own 75% of all the wealth in the state. And we've provided references on our written testimony. We realize that a tax for universal health care will not solve this wealth gap. However, any new transformative policy recommendations should actively reduce inequality, not protect those who have benefited most from it. At board and committee meeting.
Thanks, Jacqueline. It's been a minute and I appreciate your time. We want to make sure that everyone has a chance to speak. We're going to ask everyone to limit their comments to 1 minute, please. Leon Bote. And again, please submit your comments in written form. We will read all of those. Is Leon Bote? Yes, of course. You could just.
I want to thank the Alphabet for all organizers. All know about what I can contribute. And I appreciate your time. Listening. I just want, I think the common goal is I want to make sure we get done and this opportunity versus rather than just doing more of the same things. you talked about Taiwan, and I actually, as you were giving the presentation, I looked up and Taiwan does in fact have somewhat, but it's the long-term services are a separate part, but they are also university funded so I'm wondering, and I would like to kind of put this in people's minds before this meeting. If disabled people who are relying on these services are going to disabilities segregated on personal and long-term care services plan, then how are we planning to develop that separately concurrently? It's also they did it concurrently. They did it at the same time. It was not an app. We have to make sure because what happens when it's an active law is that the people with disabilities have to jump through extra hoops just to get the same privileges and opportunities as everyone else. And we need to get them.
Thanks. Thanks, Wendy. Okay, next is Patrick Lish. Apologize for pronunciation. It's fine.
Up here.
Yeah,
Just a note, yeah, please, if folks can come up to the owl, we can't hear online otherwise.
Thank you, Chair and board members. Everyone in this room is an ordinary citizen, but you at the table as board members have a power that ordinary citizens don't. Writing about racial justice, but truly speaking about human nature, Dr. King said the opponents to change, the worst opponents to change, are not people with hatred or profit in their hearts, but they're just everyday ordinary citizens who support the idea of change, but want that change to be slow, gradual, and cautious. The arc of health justice will not bend with tiny little pushes. Incremental change is what got us here today. I urge you, board members, respectfully, to use your power. Give a strong, powerful hammer blow to the arc of health justice. And you do that by using your power to propose a plan that unequivocally and boldly moves Oregon into a place where health is a social good. Thank you.
Thank you. Okay, Alex Stackhouse.
Hello, hi, board. Thanks so much for all of your work. I could not do it truly, and so I'm glad that the 9 of you are. I wanted to draw your attention to something that Isabel was able to print for me, which was the words from Valdez's invitation to you folks to participate in our 7 in-person and 1 remote town hall. And I added my name at the bottom of this letter that we printed out because I added 1 little paragraph, which was just to indicate that whatever level of participation you're able to do at these events is exactly right. I mean, if Judy, you said that you're going to go to the Dalles and be, like, I think physically present in your community with Mimi at that other meeting that we're not coordinating. And so our ideal scenario at these in-person town halls is to have a member of the board participate in person to whatever capacity you folks legally and, you know, desire to do, right? So if it's the slide deck that's been approved by the board, that's great. If it's just being present and listening, that's great. If it's remote, we'll make it work. If it's a video recorded in advance, we'll make that work too. So we're really excited about this opportunity to collaborate, and what a lift. 7 weeks from now, we'll do our first one. Thank you.
Robert?
Thank you, and Isabel, give me the little, you know, if I go over. Hey, thank you so much, Governor's Board, for letting me speak today. Valdez Bravo, he, him, his pronouns, President, Healthcare for Oregon. Just want to say, you know, it was exciting. A few weeks ago, I was at the Oregon Health Forum conversation where they're talking about the Oregon's healthcare access crisis. Have you heard we've got an access crisis? Dr. Goldberg and Governor Kitzhaber having a conversation. And Governor Kitzhaber is saying, you know, the only options we have are to lower the benefit, lower the payment price, lower the number of people covered, or reduce total cost of care. But, you know, if we can just figure this out, we need to get everyone together around a table to figure it out. That's, you know, in my mind, that's you all. He said, you know, there's a moonshot, like the moonshot is to solve this problem, but we just need like a mission control. We need a plan to chart the journey. And I raised up, as many people said, you know, why aren't we talking about the Universal Health Plan Governance Board? And he said, well, we need the mission control. I said, that is the governance board. That's what you are doing. So whether it's a playbook, whether it's the true north, we have our true north. I hope the conversations in Salem center around the work that you all doing, because I feel like this is the true north, and anything we do in the short term to stanch the bleeding of HR1, that should be in service of our true north, which is the work that you all are doing today. So thank you for doing this work, and we look forward to supporting you going forward. Thanks.
Michael, apologies, last name's Son.
Oh, he had to leave.
Oh, he had to leave, okay. And then Karen Baker,
I'm gonna pass.
okay. And then Warren George.
I'll just speak briefly from here. I did send out some public comment. When you look at the Elway poll of 2019, the common element across the political spectrum is actually dealing with the cost of healthcare. And so that we don't have to reduce services to anyone. And the only way we can really make an impact on cost is a single payer system. And I think more exactly to specify, we have to be able to control all of the ways that people serve the public get paid. And so, I'm hearing some things that back down from that. And I understand there's a lot of side winds and headwinds, not getting a lot of support from the governor's office or past governors or others, but just wanting to emphasize the importance of concentrating on staying the course and, single payer and single way to get paid. Thank you.
Mike Huntington.
Here.
Yes, so I believe that he had a meeting with all of them.
Okay, and then Rebecca Hirsch.
Hello, Governance Board.
Louder.
Hello, Governance Board. On behalf of Healthcare for All Oregon, please replace value-based care with a simpler provider reimbursement model. We have three major concerns. First, VBC increases administrative cost without saving money overall. It creates significant administrative burden for providers, which perpetuates provider burnout and adds administrative costs. Any purported cost savings come from gaming VBC's financial reward system, and this is not sustainable. Second, VBC does not improve healthcare quality or patient experience. Universal healthcare systems in other countries have extremely limited adoption of VBC, indicating that they do not see its value, and neither would Oregon. And finally, VBC worsens racial and regional health disparities. This is because it creates a system where providers are incentivized to practice in wealthier and whiter areas that tend to have healthier populations. It penalizes providers serving rural and non-white patients who are often poorer and sicker. From Healthcare for All Oregon, thank you for dedicating your time and expertise to creating our universal healthcare system.
Thank you. Thank you to all of you. And I believe we just have a final reflection from Lee. Is that it?
I just wanted to share this quote because it's something I really love. I actually do a lot of studying in my PhD program related to change. And I think what doesn't get acknowledged nearly enough is the fact that, we can all agree that change is a good thing, but change is uncomfortable. And as humans, we don't really like to be uncomfortable. And I want to commend the board because you're doing the uncomfortable, tricky work of talking about what it means to change. So I wanted to share this with you.
Thank you. Really great. Thank you. And thank you all for being willing to stay extra. I really appreciate it. And with that, the meeting is adjourned.